Yes. Say what? Wait till everybody gets here. All right. Good morning, everyone. I'm Dr. Keith Wyatt. I'm the chair of surgery here at LSU, and I've been at this institution since 1981, where I started medical school. And it means a ton to be up here today as your chair and to be able to announce the important things that have gone on this last year. So the Abramson Conference has been going on since 1972. Dr. Kurzweg, Frank Kurzweg, who is from Plaquemine, and you'll hear in my history talk later this morning, went to Harvard and University of Miami and ended up was recruited here as chair of surgery. And he thought that Dr. Abramson made such a huge impact in the 1950s when he was chair, helping us getting certified by the American College of Surgeons, amongst other things that he did throughout the community. And he passed of a heart attack, as did his father, years earlier and during his chairmanship here. So we honor him, and we continue to honor him on a yearly basis. Normally what we will do during this conference during the morning, we have a visiting professor, and I felt so strongly about inviting Dr. Carter LeBairs, who is an associate professor at University of California at San Diego, after I heard her talk on wellness and timeliness of taking care of each other and taking care of yourself and well-being at the American College in Boston. It really touched a lot of the chairs at that time, and I asked her 6 months ahead of time to come give this talk, and she said, look, I will be there, but I have a family vacation that I go to every year. So she's flying out of Minneapolis this morning and will arrive about 2 o'clock. So she apologizes she couldn't be here. So we've changed it up a little bit today. Typically, the chief residents and the people who do research would come up and present. We wanted to kind of have a laissez-faire, more of a fun time during this conference instead of being so rigorous with research, competition in that fashion. So we're going to break this up into case presentations this morning, and I would encourage the faculty to also take these questions, because I think they're going to be challenging. And if you're going to recertify, if you hadn't yet certified, I think it would be challenging for you, especially the ethical questions. So the format for this, which will go from 8:30 to about probably 9:30, I doubt it'll last an hour and a half, will be case presentations by Dr. Richardson, Dr. Chapman, Dr. Larimore, and myself. And we were going to do this electronically, but we went to the old paper method since we had some problems with connectivity here. So you will be asked 4 questions per unit: general surgery, trauma, critical care, surgical oncology, and surgical ethics. There is money at the end of the day for the winner. So we will grade these individually, and the person with the greatest score, the highest score, will get some money at graduation and be recognized tonight at graduation. These are not easy questions. And then we will grade according to PGY level. So PGY 1 through 5, whoever does best cumulatively will get recognized tonight. Now, we didn't have enough money to give all of those 4 or 5 residents. We would expect that the PGY 5-year would win this award because they have the most experience in taking tests. So let's see if the PGY 4, 3, et cetera, can upset the senior residents. Now, during my ethics questions, I have 7 questions, but you can only answer 4. So pick wisely, and you'll say, goodness, is there a right answer to some of these questions? Yes, there is. So only pick 4. So if you're not sure of the answer, don't put the answer down. We're going to go through this conference this morning in a time, kind of a quick fashion. We probably won't last until noon. My talk is right at an hour, so when we're finished with the case presentations, we'll take a short break for some refreshments and some fluids, and then we'll come back and I'll give my talk, and then we'll present the surgeons, the graduating chief residents, their chairs. So without further ado, we are on YouTube, so what said can be held against you. So just remember. All right, Dr. Richardson's here for the first general surgery case presentation.
Good morning, everybody. Okay. Print's pretty small for me. Okay, so this is a general surgery case. I think Dr. White wanted kind of a spirit of not ethical, but a diagnostic dilemma maybe, but mine is, I think, more is a trivia question, but it was kind of interesting and kind of puzzled us a little bit. So, history, fortunately, is very short. 66-year-old male presented to the emergency room for unrelenting central abdominal pain. He described the pain as a 7 out of 10, and he described it as tightness. He had had previous similar episodes that were not as bad or as long, but these would resolve spontaneously. He described feeling what he said was blocked up. For the last few days, he took mag citrate at home, had a small bowel movement with no relief, so he called EMS. He reported 4 days of nausea and vomiting for 2 days prior to presentation. He's never had a screening colonoscopy. He denied any weight loss. Fortunately, other health problems are none, no medicines, no surgeries, no allergies, no bad habits except for an occasional rare cigar. Okay? Nothing alarming yet. And about here's where we got consult in the ER. You're like, while you're down here, come see this. You're like, okay. So his exam, he was afebrile, temperature 98.2, heart rate 86, respiratory rate 20, normal blood pressure 132/82, 6'4", 210 pounds. Very fit, healthy looking 60-year-old man, no distress. I'll focus on his abdomen. The rest of his exam was benign. No scars on his abdomen. I did not write that down. He was distended. He did not have peritonitis. Immediately above his umbilicus, he had a non-reducible hernia. The hernia mass was about 6 centimeters, and we could not palpate the fascial edges below. Labs, white count normal 5.6, hemoglobin 13, CMP normal, lactate 2.3. Again, we're getting consulted here, and we're like, okay. So that's where we started. That's where we encountered the patient. So here's my first question. What now? So everybody's answering in pen, right? Okay.
These grades won't be posted, okay? It's not public domain.
I disagree. I think they should. Okay, everybody ready? We did have this flat and upright. A CT had been ordered, but we decided to forego the CT. So based on his distension and the tender hernia mass, we took him to surgery for an incarcerated hernia causing kind of an early small bowel obstruction. We performed a midline incision over the hernia, a little bit above, a little bit below. The sac was dissected free from the subcutaneous tissues and opened. We saw a viable knuckle of bowel, but it had this thin membrane over it. We were able to reduce it through a 1.5 centimeter fascial defect. The membrane kind of puzzled us, so we extended our excision a little bit. And this is what we found. It's a little bit hard to see, but here's a loop of small bowel that's kind of dilated. There's another one here, and there's kind of this sac overlying this. This is some momentum that's kind of pulled down, okay? So the entire small bowel was encased in this second sac. We could identify the knuckle of bowel that was in the hernia. It was just one wall, so a Richter's hernia. All the bowel was viable. And we could explore from this opening that the duodenum and colon were in normal position. So here's another picture. This is from a medical journal. I found some articles, and I can share these with y'all later. But this is a more kind of stylized picture, a little bit better picture of the sac with all the small bowel within it, viable small bowel, and the transverse colon is lifted up. The head of the patient is up here, feet's down at the bottom. Here's kind of a cartoon of what's going on. The one on the right is a more stylized version. It's not quite like this. This is more indicative of it, where there's a leaf of the mesentery covering the sac of the small bowel here. Google images, very helpful. If we had a CT, it would have looked something like this.
Would the CT scan have changed your approach? Did you have one?
Not mine. I think another surgeon, probably more versed in laparoscopic surgery, might have addressed it laparoscopically, but no, I would have cut down on the hernia just like I did. Okay, everybody got a good look at the CT?
Patient had AKI from all this. When you go to the OR, so like start the hydration and then do the perioperative hydration, but you still go to the OR.
Yes. Was that a question? Statement.
Kind of easier because
No, I would have hydrated. I mean, we started fluids, talked to him. We had a couple of hours to hydrate him before we went anyway. I mean, he was in no distress. He did not have peritonitis. We thought we were going for just a simple incarcerated hernia. Okay, so everybody good with the CT? Here's question number 2. What is the most common primary internal hernia? I'll read the answers. A, right paraduodenal hernia. B, left paraduodenal hernia. C, pericecal. D, foramen of Winslow. Anybody answer? So our operative contact, we opened this second sac distally on kind of the thin wall away from the hernia defect and followed the sac up toward the defect. The entire small bowel was examined and reduced through the hernia defect. We excised the distal part of the sac with interrupted silks to close the defect, and we closed the abdomen. Here's probably the hardest question. So which blood vessel or blood vessels are at risk of injury in repair of a paraduodenal hernia? So choice A, SMA and SMV for a left, inferior mesenteric vein for a right. Or the opposite of that, SMA and SMV for a right paraduodenal hernia, and inferior mesenteric vein for a left paraduodenal hernia. Or SMA in both, or the middle colic artery.
Setting the curve. Yeah.
That's a tough one.
you need to use the mic.
This one? The outside one? I'm sorry. Okay. Sorry.
No, this mic here. I think that.
Oh, out there? Okay, I'm sorry. Everybody cool? So the post-op course, very uneventful. Post-op day 1, we removed our NG tube, started on a liquid diet, pain control, no problem. Post-op day 2, advanced to a regular diet, had a bowel movement, transitioned to oral medications, and discharged. Saw him in clinic 2 weeks later, said he'd never felt this good. That was satisfying for us. Here's the last one. What's the name of the fossa of a left paraduodenal hernia? Waldyers, Lanzerts, Winslows, or Trites?
It's like a Jeopardy question as well.
When you list all the most common internal hernias, does that exclude a post-operative internal hernia? And do you close the mesenteric defect when you take a piece of the bowel out? You don't have to answer. What about other people? What is the current literature support? Should we close the mesenteric defect after doing a bowel resection?
Honestly, I don't know the literature. I know we all close them and don't know what happens after that. But the true most common internal hernia is a post-operative. What we're talking about here is a primary one.
You actually don't have to close the mesenteric defect. It doesn't increase the rate of internal hernia.
So colorectal surgeons don't close it. General surgeons and ped surgeons close it.
Dr. Richardson, thank you for that. Great case. I'm going to give a hand to Dr. Richardson. Thank you. That was challenging, no doubt. These questions are not the kind of questions you'd get during an oral exam, but not dissimilar. Most of these are extremely straightforward in your oral exams where they're almost predictable. To be a safe surgeon, to be predictable and not doing things that would place you in kind of someone who's just cavalier during some of these surgical procedures. So Dr. Brett Chapman's one of our assistant professors in trauma now will present our trauma case. I'm sure he's got something good for us.
We'll see.
Sneaky guy.
I thought mine were going to be hard, but they're going to be a cakewalk compared to Dr. Richardson's. So. Mine are sort of within the flow of the case, so you'll have to answer it to move on. So I'm going to trust you guys not to fudge the answers, I guess. All right, so we'll go through my case. I have no disclosures. I'll just tell you that we're going to be a little bit fast-paced because trauma is fast-paced, integrating information quickly, so I'm going to try to emulate that as we go through. So you get a call from EMS to the hospital saying that they have a patient en route. They have a 17-year-old male in an MVC. He was interstate speeds, rear-ended a log truck, and they said the vehicle was impaled. So he has a GCS of 12 for them on arrival or on contact on scene. Systolic blood pressure 105, heart rate 117. They're 4 minutes out, so you call a tier 1 activation for the GCS and the borderline vitals. So they arrive to the hospital, get him over to the stretcher quite quickly. They give you a report and add the details that he was going about 70 miles per hour. The log truck was slowed for some construction, and the driver just rear-ended the back of it. They tell you there's significant passenger compartment damage, and then again they imply that the respirations over that right chest. Circulation, he's got strong and symmetric pulses, and the radials, his DP pulses are a little bit more diminished, but they're symmetric, and no uncontrolled external bleeding. Disability on your assessment, he's GCS of 7, so continuing to slightly slip. Now eyes to pain only, not making any noise whatsoever, and still withdrawing to pain. He's got discordant pupils, left being more dilated at 5 millimeters, and again, he withdraws to pain in all 4. The exposure, you remove all the clothing. He is diaphoretic. He's got a hematoma on the left frontoparietal scalp. He's got ecchymosis over that right chest wall where you know there's some issue, and he's got scattered debris. Pressure of 84/40, MAP of 55, heart rate 131, shock index is 1.6. Dr. Parrish, is that high or low?
The second.
That's correct. It's okay. And then his sats are now 99% on 15 liters non-rebreather. So you saw that mid 95 sat on face mask, and you escalated it. He's tolerating well. So the patient's mother was able to sneak through the ambulance bay door. She followed the ambulance to the hospital. She overhears you say, get us some blood now, and she chimes in, we're Jehovah's Witnesses. He can't have blood. He doesn't want it. What are you going to do? A, hold the blood transfusion. B, proceed the blood transfusion. C, ask for an advance directive. Or D, call for EPO and ask about other adjuncts. 15 seconds. Let's go. We'd love to do that, but security also takes a little bit of time sometimes. So. 17.
So ethical and procedural.
Encroach on Dr. White a little
and
bit.
And medical legal.
The rest are more clinical. All right, who put A? Throw your hands up. B? Wow, that's a lot of hands. All right, C? Anybody? Nobody's worried about getting sued? That's good. D? All right, Dr. Baldwin, why is it B?
Not going to do well about their products, and he's not able to consent for himself or deny
Correct.
himself.
Yeah, we don't let kids die over things that may or may not be true, right? He's a minor, so he also can't participate in the conversation, so you can't ask him, and you can't really take anybody's word. Y'all hear me say this all the time. We don't do paperwork in the trauma bay, right? Those are things for after. We're focused on life-saving in the trauma bay. So there's a very good reference for you guys to look at if you're interested. It's a statement from the American College of Surgeons from 2028. I can give you the link if you like, but it goes through a lot of these points about emergent things, non-emergent things, children, adults, when to go for court orders, things like that. So I would encourage you to look at that. A few snippets just from that I'll put up here, and y'all can read through these while I kind of give you the general consensus. But it's basically what Dr. Baldwin said. When things are in an emergent setting, the patient cannot participate or does not have the capacity to participate. They're intoxicated, they're obtunded from a trauma. You are well within your rights and your justifications to do the standard of care. And the standard of care in a hypertensive patient is to give blood, period.
Dr. Chapman, you say you look at the EPIC record, and it was in the EPIC record that he didn't take blood and he was Jehovah's Witness. And this was done for a procedure maybe 3 months ago. Well, would you have done anything different?
Probably not, because I think in people who are faced with true life or death consequences, their decisions often change. In a reality standpoint, these usually are known patients, so we know that's mom, but we don't know the patient's name, date of birth, all that yet. That kind of gets handled as we go. So I doubt we would have access to his chart right away. But even if we did, if I can't talk to that patient, I would do the standard of care.
Got it.
All right, and then specifically related to kids, they encourage you to accommodate some preferences but not others. So just to quote this, in general, family and even patients who are under 18 cannot refuse life-saving treatment for a minor patient. So this is the key one here. It's not acceptable to let a child die from anemia, from something you can correct because of someone's religious beliefs, especially the parents or guardians. And then there are certain situations also where you can argue that a 15-year-old does not truly understand the concept of death and is not, even if they say the right things, are they parroting someone else? Is that truly what they believe? Do they really understand it? So there are certainly situations where you can even override the patient's wishes if they're under 18. So in general, you will always be safe if you do the right thing and do the standard of care. All right, so you give 2 of blood, 2 of plasma via the Belmont. The Belmont can put in 1,000 milliliters a minute, so this takes about 90 seconds to get you 4 units of products in. You place the right femoral ley line. Your blood pressure responds to 102/68. Your MAP is now up to 79 from 55. Your heart rate is down to 108. So you do your fast. Dr. Brumley, what view is this and what do you see?
Okay, just a second, use this.
A view of the hepatorenal space, and you can see blood between the liver and the kidney.
Correct. So that black is fluid, right? Presumed hemiperitoneum. You did a left upper quadrant view as well. The splenorenal fossa, you also see fluid here. Your suprapubic and your subxiphoid views are normal, best you can tell. Your left anterior chest is normal. You see the classic seashore sign or the ant scope marching on a line to indicate lung slide. The right side, however, you don't see lung slide, and you get the classic barcode sign. This is your chest and pelvis plain film. The pelvis plain film is normal. The chest is not. Dr. Richard, what do you see?
Okay, use this, please.
We might need to dim the light. That's fine.
So I'm looking at the chest film. It looks like there are some rib fractures on the right there.
You can't really see it, but there's a little line right here.
Where?
Right here. Where the mouse? Oh, you can't see my mouse. Okay, it's about 1/3 of the way up. Right over the clavicular head, there's a line there where the lung is inflated inferior but not caudally. So you have about probably a 30% pneumothorax at the apex and a caved-in right chest, as you can see there, like you mentioned. We'll blame the lighting. All right, so your A-line still has a good waveform, and after you get these studies, your blood pressure then drops again to 86/44. Your MAP's under 60. Your heart rate's back up to 128. You call for more blood. So far your injuries are hemorrhagic shock, a closed head injury of some sort, presumably, encephalopathy, whether that's toxic. He ran in the back of a log truck that was on the road, right? So you don't know if he's intoxicated, or this is just traumatic injury, or perhaps a combination of both. A right chest wall injury, right pneumothorax, and presumably hemiperitoneum of some quite significance given his vitals and his transient responder status. All right, so what's the next best step in management? Do you want to intubate him to control the airways? Got a GCS of 7. Place a right chest tube to decompress the right chest. with a known pneumothorax and chest wall injury, diminished breath sounds. Do both at the same time or go straight to the OR? 15 seconds, let's go.
Brett, I think on the chest X-ray there was a deep sulcus sign also, right? On the right, on the left side.
I didn't see it.
No strike throughs. Okay, you got to answer those in 15 seconds.
All right, who thinks A? Intubate, GCS less than 8. All right, right side of chest tube? Nobody. All right, y'all like pneumothoraces? Both? All right, so we want to do both. More hands, and then straight to the OR. All right. Why do you think straight to the OR, Dr. Who raised their hand? Lambert?
Here we go.
I'm not picking on the fives today. Y'all get a pass. You've earned a pass.
So he's maintaining his airway on his own, even though his GCS is decreased. So no real need to intubate right away, and we can place a chest tube in the OR. But as Dr. Colvin says, the OR is where we can fix stuff. So that's where we need to be.
Love it. Yes. So he's set 99% of non-rebreather. His GCS is 7, but he's protecting his airway for now. So there's a really good paper that came out last summer that put a lot more level 1 evidence on some of the concept a lot of us had known for a very long time intuitively, and previous studies have been underpowered to show or to prove. And that's that ER intubations in people who are truly undergoing hemorrhage control surgery is the wrong thing to do. So what happens 99% of the time is circulatory collapse, code, ER thoracotomy, death. Right, so that is not the best location. I'll go through this quickly. So there's a NTDB retrospective review. They had 253 participating level 1 and level 2 trauma centers, which is a huge number. They had pretty strict exclusion criteria, so they got still around 10,000 patients from those centers, and these were specifically people who underwent hemorrhage control surgery within less than 60 minutes of hitting the door. They minimized things like people who were no signs of life or DOA shortly on or shortly after arrival, ER thoracotomies, and then people who were intubated for clinical indications only, like airway protection from craniofacial injuries, GCS less than 8, purely mental status things. So they tried to exclude as many people as possible to truly get a finite group that they could actually make conclusions about. And they controlled for patients' baseline characteristics, mechanisms, injury severity scores, specific injury diagnoses on an ICD-10 level, their initial vital signs on arrival, and then the actual operation they received. There was a quite significant increased mortality in people who were intubated in the ER. So 10% or more than double. All right. There was a longer ER dwell time of almost 33%. The increased blood transfusion at 4 hours was double. And then increased major complications quite significantly. You can see P less than 0.001 in cardiac arrest, AKI, ERDS, VAP, and even sepsis, still very significant, but slightly less so. So ER intubations dealt with a lot of bad things. So the take-home point from all this is when feasible, and someone who is truly in extremis, truly hemorrhaging, going to the OR emergently, the best place to take care of them is in the OR. All right?
So
Yes?
They
They need to be intubated, but it's a matter of should I do it in 5 minutes or should I do it here? Because if I RSI them and they have a circulatory collapse, you're going to be stuck.
Okay, I just asked if you still intubate everybody for GCS less than 9. That's what we did.
Depending on the circumstance. So this patient certainly needs to be intubated, but if you intubate them in the ER, they're going to lose all their vasomotor tone, they're going to code, they're going to be stuck. Then you're in the ER without the instruments, without the capability to actually take care of the problems.
How many times have you seen an occult pneumothorax after intubation turn into a tension?
It happens.
And it does, but I'm thinking back in chest trauma, not a lot.
Right.
But it's unfortunate, it's fatal.
Yeah.
A huge, especially someone goes positive pressure ventilation, they're really bagging the heck out of the patient, he's hypoxemic, and you turn that into a pleural flap and
I think commonly in trauma, and this was a pretty severe chest wall injury on the plain film, but commonly you have a displaced rib, it punctures the lung, you have some air leakage, and it's not going to be an ongoing problem. A lot of those patients we decompress, chest tubes come out pretty quickly, but there's no way of knowing. So the next slide will go into it. This is a patient where you would have them prepped and draped and ready, and you'd be putting the chest tube in while they're inducing. So you want to kind of control all those parameters because you know the chest tube the chest might become an issue. You know when they induce, they might have circulatory collapse and code. So you got to be ready to go immediately on intubation. So as you're getting up to the OR and getting them prepped and on the table, they get another PRBCs ×2, FFP ×1 into the patient. You get prepped and draped before you induce anesthesia, like we mentioned. Thankfully, your pre-induction vitals are relatively reasonable, and he is induced without issue. You place the right chest tube, the second-year resident does right as they're starting, while the attending and the chief are starting the laparotomy at the same time. So immediately on entry, you get a large volume hemoperineum. You pack expeditiously in all 4 quadrants, but even with that, you get the pull sucker puts out about 1,500 of blood right away, and you get about 24 laps in all 4 quadrants before you thankfully get pretty good hemostasis and allow anesthesia some time to catch up. So the injuries you identify: a grade 3 spleen, so a 3-centimeter laceration in the parenchyma from the lateral mid-spleen all the way down to the inferior pole. Grade 2 liver, long but not so deep, relatively hemostatic. And then a small bowel mesenteric avulsion or bucket handle injury in the TI that's 25 centimeters in length with active bleeding from the mesenteric margin near the root of the mesentery. So your liver laceration is hemostatic, of little concern at this point. Your spleen is oozing, you pack it off to come back and look at later. You address the bleeding from the mesentery and then perform your ileocystectomy to address the most active hemorrhaging issue. And then your introp ABG here, so relatively normal, a little acidotic, base deficit of only 4, your hemoglobin is 8, which is reasonable, your temp is 36, so you're not hypothermic. So your spleen laceration, when you go back and look at it, it's still oozing. You've tried some conservative measures, some topical agents, argon, unsuccessfully. It's hemostatic when you pack, but otherwise it oozes every time you try to take it off and address something. So you're ready to close, you're ready to be done, but you just can't stop this issue. So what do you want to do? Partial splenectomy? Splenectomy? Continue to try to other salvage maneuvers, other agents, other things like that, or pack it and close temporarily. A lot of things to consider here. You have a 17-year-old, you have an unevaluated head injury, presumably. So a lot of things to consider. Huh? Yeah. They're on it today. Middle of the day, everybody's available. 30 people in the room trying to help you. Who thinks A? Partial spleen. B? Total spleen. All right. Best case in the world, trauma spleen. Splenic salvage. No one wants to stay and play? All right. And then pack it and temporarily close the naphthera. A few hands. All right. Who did spleen again? Total spleen? Dr. Kendall? Why do you think? I told you I wouldn't pick on you because y'all were the night crew. I'm sorry.
It's okay.
You're the first one I saw.
Especially in the setting of an unknown head injury, you don't want any oozing and getting hypotensive. So
yeah, this patient has a lot of considerations, right? He's technically a pediatric patient. He's 17, but he's near adulthood, so he's probably had all the immunologic function he needs from that if you had to take it. You want to evaluate that head injury quickly, right? So you don't want ongoing hypoxia, you don't want ongoing hemorrhage and blood loss, you don't want hypotension, and you also want to get the hell out of the OR, right? So you can evaluate that and see what you need to do about it. The other consideration is this guy's a Jehovah's Witness, so what if, like Dr. White said, you wake him up and he says, no more blood from here on out? What if you ooze because you did something conservative and your spleen's just kind of drifting, your hemoglobin gets down to 6, 5, 4, right? So with a total splenectomy, the problem is handled, right? Your ongoing blood loss should be none. Spleen's out, should be dry. So that's what you do. You do your splenectomy, you close your abdomen, you transport him to the ICU. Your post-op labs and TEG are reassuring, and so you take him down for your CT and you see this. So obviously a large intracranial hemorrhage, mass lesion, midline shift. You administer hypertonic saline quickly. You call neurosurgery. They take him for a decompressive hemocraniectomy quite promptly. Post-op, his GCS responds to a 9. You're encouraged. And then 6 hours later, he's down to a 3T. So you take him rapidly for another CT head and see this. What's the next best step in management? Nothing further. This is expected. Osmotic agents, hypertonic saline or mannitol. Put a bolt in, an ICP monitor, or do a burr hole. That's my trivia. Who thinks A? Expected post-op CT. All right. B? Hypertonics, mannitol. All right. ICP monitor? No one? Who wants to drill a burr hole? Man, some people want power tools. I like it. Dr. Eckel, did you raise your hand? For burr hole? Why? What is this? Any idea?
I think, like I said, inadequate decompression. If they did a left side and now he's got pressure building up on the right side, he needs some way to quickly relieve it.
So you think this is more blood over here? Or this? What is this?
It looks like air. It doesn't look like fluid.
What's the black stuff at the top of the screen?
Air.
Okay. Do you see more hemorrhage that needs to be decompressed?
No.
Okay, so what is that air? Why is, that's a lot, right? It's more than
Yeah.
normal. You know what that sign is called?
No.
So this is called the Mount Fuji sign. Quite a fun name, right? So this is a tension pneumocephalus, which is rare, but does happen. I've seen one. So the way this happens is that when they're on the way out, usually the dura is not completely closed. And so you get sort of a ball valve flap in the dura. So you can get air in, but it can't actually escape. So this can be the same clinically as a big mass lesion of blood, right? It's a tension pneumocephalus. You get this pressure usually on the frontal lobes, but it splits kind of in that anterior falx area, and you get that little V gap right there in the center. So this is tension pneumocephalus. This is a surgical emergency, right? Usually the first thing to do is do a burr hole because it's quick. You can do it at the bedside, but that patient ultimately has a high chance of needing another cranie to repair the dura and to vent that air. All right. This is a zebra, but you might see it one day. So. Yeah. Mount Fuji sign. Dr. Samra loves this sign.
Yeah, it's a volcano, yeah.
All right. Well, you guys are on it. You get the burr hole done. His neuro exam improves over the next few days. He gets extubated on hospital day 5, goes to TBI rehab on hospital day 8, gets his spleen vaccines, and you see him in clinic. He does well. Good job. Questions?
That was
Survive
great.
that
That was
impalement.
great. Thank you so much. What's going to happen if there's a tie, an individual tie? Well, we'll add a little bit more money to the pool so everybody gets an equitable amount of cash because of their hard-earned efforts. So we'll come up with that. I'll pass the hat around and we'll come up with a little bit extra money. Third case, surgical oncology. Dr. Terry Larimore, tenured professor here that's got vast history of surgical oncology in St. Louis at Barnes Hospital, Washington University, and also in the Dallas area. So, Dr. Larimore, it's all yours. Make it tough.
Thank you. I just want to say congratulations to all the graduating chiefs. A very important transition in life. I remember it well. To still be standing at the end. Job well done. So I advance this way. Is this it? Where's the advancer? Is it right here? Right here. Here we go. Got it. I'm part of the old guard.
It's okay. Did you get you packed
Yeah,
up
we
your-
should be up. Okay. Great. Here we go. Slideshow. So this is a case that I'll present of melanoma. It's actually a case of Dr. Morano's who assisted me with the presentation. If you have any complaints about the presentation or the answers, Dr. Thayer would be happy to field those for you. So let's see here. I think it's going to be easier to move forward like this. The patient is a 75-year-old male who presented with a pigmented lesion on the dorsum of the right foot. He gave a history of a pigmented lesion, a mole that had been present there from at least 10 to 15 years, but recently noticed that it had enlarged. And again, this was right on the dorsum of the foot. As is commonly the case, a shave biopsy, not a full thickness biopsy, was performed by dermatology, and the pathology revealed an acral lentiginous melanoma with a Breslow's depth of 2.1 millimeters. And not listed here, but I'll also tell you there was evidence of ulceration and also increased mitotic rate. So this is a fairly healthy 75-year-old man. He's actually a retired local police officer. Had hypertension, type 2 diabetes, mildly obese. Only past surgical history was that of a left inguinal hernia repair in 2007. He took the medicines as listed there. So you think about how you would start working this patient up. Is this a low risk, high risk melanoma? What do you think? It's very high risk, okay. And so you take him to the operating room to take this out, and you're going to do a wide excision of this, and also have to deal with staging of the nodal basin. So this is the preoperative of lymphoscintigram, which demonstrated uptake in one of the right inguinal nodes, which indicates that it's the sentinel node. So you take the patient to the operating room to perform a wide local excision. The questions will be coming here. And you also stage the regional nodal basin with a sentinel lymph node biopsy. And then the wound was actually closed after that with Integra, pending the final pathology. So this is the first question. The questions start more simply, but this might not be as easy a question as you might think. What margins of excision are required for this Breslow depth of 2.1, also a very high-risk melanoma? And does your answer change based on where the melanoma is located, okay? Sometimes it's not achievable cosmetically or functionally to achieve the margins that might be recommended. So what type of margins you think you need for this melanoma of excision? I'm going to go with the pattern of Dr. Richardson and not reveal the answers during the presentation. So everyone knows what kind of margins they're going to get based on the dorsum of the foot. This is your pathology from both that and you perform a sentinel lymph node excision. The pathology demonstrates a T3B in one, because you have one of the two sentinel lymph nodes is positive. It's BRAF mutation negative. Postoperatively, the wound seems to be healing well. And then subsequently, you perform a metastatic workup based upon this positive sentinel node, which shows no evidence of residual disease or distant metastatic disease. What is the next best step in this patient's management? A, superficial inguinal lymph node dissection. So you have a high-risk melanoma, you have one of two positive sentinel lymph nodes with microscopic metastases. So are you going to take the nodes out? Are you going to surveil the patient with ultrasound? Are you going to do ultrasound and also give the patient adjuvant immunotherapy with a checkpoint inhibitor, PD-1 inhibitor? Or are you going to give adjuvant immunotherapy alone? So those are your options. Everyone got their answer? They know what they're going to do. Does everyone know why they're going to do it too? What's the... Dr. Morano's going to be very upset with you if you miss this one, based on his... So after discussion with the patient, it's agreed upon to perform ultrasound surveillance of the nodal basin every 4 months for 2 years, and then every 6 months for 3 years. He's also discussed at multidisciplinary tumor board and medical oncology based on high-risk stage 2 disease to give him adjuvant immunotherapy. It's stage 3, right? Stage 3. It's not a stage 2. So after a year of adjuvant pembrolizumab, his 2-year follow-up ultrasound now demonstrates an enlarged right superficial inguinal lymph node. And PET scanning is performed, which demonstrates 2 PET avid nodes in this right inguinal nodal basin, but again with no other evidence of metastatic disease. Percutaneous core biopsy is performed, and it does confirm that you have metastatic melanoma recurrent in your nodal basin. What are you going to do now? What's the next best step? And why is it the next best step? What's the data for it? It just demonstrates a PET scan. It's actually this patient's PET scan. It demonstrates this bright node in the right inguinal region. So what are some potential recommended options for further management, okay? There may be more than one potentially correct answer. Number 1, therapeutic lymph node dissection, complete lymph node dissection. Number 2, give the patient neoadjuvant immunotherapy, then take out their lymph nodes, and then give them some more immunotherapy. Should you just go and take out the nodes that are positive? The PET scan only shows one node or 2 nodes. Should you go and cherry pick those, take them out? Should you give radiation therapy? Are both A and B acceptable answers based on guidelines? Can you take out all the nodes? Can you give them immunotherapy plus that? Or A, B, and D? Does everybody know what their answer is going to be? Dr. Thayer, you know what your answer is? Okay, don't tell us. I know Dr. Thayer's answer too. So I hope that chief residents have all had the opportunity to do an inguinal node dissection. It's actually quite a morbid procedure. It's not an easy procedure to perform. Many people, although I have not done it, are actually doing it laparoscopically now, endoscopically, with good results. We probably should try to put that in our armamentarium. One of the problems with these node dissections is wound problems are very, very frequent. So it's a morbid procedure, and it's also not performed well by people who don't perform a lot of them, as is the case with a lot of our procedures we do in surgery. You can see here, though, the indication that of the anatomic landmarks of the sartorius muscle and the inguinal ligament. And basically, you can see here in this picture that if you do a complete dissection, you pull all the nodal packet superiorly, you can see the pectineus muscle medial to the vein and skeletonize all those structures. So this just demonstrates the NCCN guidelines. In the nutshell, if you look at it, basically if you have a nodal recurrence, biopsy it to determine that it's recurrence. If BRAF testing has not been done, it should be done. You should evaluate them for systemic disease. If the disease is limited to the nodal basin and there's no previous lymph node dissection, you can give the patient neoadjuvant therapy, systemic therapy. You can see the different acceptable options there, and do a nodal dissection. So you should be aware of those guidelines. So the pathology, so you do a therapeutic lymph node dissection in this patient. It shows 2 of 15 lymph nodes that are positive for metastatic melanoma, BRAF negative. The patient has started on more adjuvant immunotherapy and continues to undergo surveillance for recurrence. At 9 months after follow-up, the patient complains of 4 small dark nodules which developed along the right calf. And PET-CT demonstrates that these are avid with no other evidence of distant disease. They're biopsied, and they do, in fact, confirm that they're malignant melanoma. What are you guys going to do now? It's localized disease to the extremity. Anybody going to do IL-2 or melphalan or hyperthermic isolated limb perfusion? Anybody want to do any of those? What's the next best step in management? So here are the choices. And this is the last question, I think. Number A, wide local excision to achieve R0 negative margins. B, change the systemic therapy to cytotoxic therapy. C, give some radons, give some X-ray therapy. D, amputation. Or E, could you give TVEC injections into the local site? Everybody have an idea what they might want to do? There might be more than one answer here that is acceptable. Okay, I don't think I'm going to reveal the answers at this point in time, unless you want me to, but it's up to you. Okay.
Dealer's choice. Thank you, Dr. Larimore. Appreciate you so much. Thank you. I'd also like to reflect what Dr. Larimore said about the Chiefs. Started 5 years ago doing exit interviews. You know, it's a Fortune 500 best practices to, on the way out, get an idea of what your residents or your employees think about who you are, what your company consists of, what your resident consists of, and how can we do better in the future. And this has been, over the 5 years, delightful. So. This group has decided to focus on the positive, despite several challenges from an institutional viewpoint. This medical school, which you'll see in the hospital, which you'll see in my discussion and my talk in about an hour, is that it's been challenged economically, politically, in several different avenues. So practicing medicine here is very difficult, but they have superseded anything that I thought that they could have done. So. Thank you for all your service. I know that sounds military, but it's true. You've done a ton of work. You've saved a lot of lives, and we appreciate you. And thanks for what you did. And thanks for the interview. We had a great dinner last night at the Shreveport Club. Traded jokes, traded some great stories about some of the attendings here, which I may or may not share. But the surgical ethics is, to me, the most challenging portion of my practice, I guess, over the last 30 years. Like I tell the residents on their way out, it's not the Proline, it's not the Vicryl, it's not the staples, it's not the staplers that gives me angst. It's those decisions about what to do, what not to do, and my response to some of the things that occurred during my residency. Some of those things you say to other people, some of those things that you incur or infer to patients are the things that keep you up at night. And it will continue to do that. So it's an evolution of your practice on how to deal with the situations you're about to be presented. I will say that these seven questions, I'd like you to answer 4. So if you don't like the first question, you can wait till the very end, but you don't know if they're going to get more difficult or easier. So do the ones you think you can do and get right. And we won't go through the correct answer, but I will go through each response in great detail and ask your comments on why you would pick this and why you would not pick this. Some of these are very difficult to know. Some of them are legally bound, that you need to do the legally correct thing. Some of these are bound by local law, hospital policy, but most of these are your gut feeling about what should I do in a situation like this. All right, so the first case is a 58-year-old male. He's involved in a motor vehicle accident where he was an unrestrained passenger and was ejected from the auto. We all know what that means, bad news. Happens quite frequently in Louisiana, where 17 to 20% of people still decide not to wear their safety belts. He has a GCS in the trauma bay of 15, has recurrent hypotensive episodes in the trauma bay, recalcitrant to fluids. His FAST was positive for a large amount of intraperitoneal fluid, and his hemoglobin was 7 grams per deciliter. It may not be as eloquent as Dr. Brett's, but it's nonetheless a trauma patient. He was taken to the operating room because of his hypotension, large amount of fluid, and persistent problems with his blood pressure, and where a grade 5 splenic injury was treated with a splenectomy, done very expeditiously and very quickly. His hemodynamics improved after resection and blood administration. His abdomen was closed after reported correct sponge and needle count by not only the scrub tech, but also the circulating nurse, and this was 3 a.m. in the morning. He developed abdominal distension and a fever post-op on post-op day 5 of 102, mandating some studies. Okay. Make sure you look at this, because this is all of our worst nightmares of seeing a retained foreign body in I guess this is not working. Retained foreign body in the area of the left upper quadrant here. This is a drain that was placed in the bed. You're obviously concerned. You talk to your attending. So your attending speaks with the patient's wife, post-operative day number 5, and he asks you to go ahead and sign the patient up for an abdominal exploration. As you speak to the wife, she's rather upset and feels horrible that he has to go back for this, and ask how often this happens, as the attending told her that they frequently leave sponges in the abdominal cavity so as to soak up the remaining blood. This was an actual statement by the attending physician. So, in the avenue and the environment where I think no harm to the patient has to come from every level, I think the residents can no longer be afraid of the things that can happen when they talk to their attending about ensuing ethical problems. I think you're bound by your own personal striving for good patient outcomes and being honest, that sometimes you have to talk to your attending. You have to say, I don't agree with that. And if you don't, I think you're bound by ethical problems in the future, because nobody is above good patient outcomes. Nobody's above that. So I think it's important. So what do? Tell the wife that this was true. So you agree with the attending, although you know this was not his intention to leave this in. Ask your attending why he told the wife this statement. Report this to Dr. Sitt, program surgical director. Or you go to your mentor and say, what do I do? How can I rectify this? So put your answer down. This actual case. There's 2 theoreticals and 5 actual cases. Now, this is not the first time this has happened at LSU. Whereas the surgeon never dictated in his operative note that this was left in for hemostasis, but in finding these on some surveillance radiology studies, found this to be true, and it was told to the family. I've taken laparotomy sponges and foreign bodies out in intervals of 7 to 10 years in the chest. People had had empyemas, had it packed off with sponges and laps, and found a huge phlegmon in the chest. And the statute of limitations starts when discovery is made, not when the lap is left in. So the patient comes to you, and she said, Dr. White, I mean, my previous surgeon didn't tell me about this. It's not the 2 years that it happened. It begins immediately when that patient knows about the event. So it's a never event. These are the events that keep you up at night. I had a patient, my second or third case at Shumpert at the old hospital, that had a cabbage bleeding, had Plavix and aspirin. When Plavix first came out. It was a Saturday morning. I didn't do a lot of cases there. I didn't know the scrub team. Doing an emergent cabbage with people I didn't know, and I left a small sponge around the heart. I got that chest x-ray, and I can imagine you'll get this feeling. Hopefully you won't get this feeling, but what do you do? So the patient's daughter was a nurse, so I went and talked to her. I said, we have a sponge in there. I think I can make a small incision and remove the sponge, which we did. And she told me, thank you. The patient had an uneventful recovery, went home in about 7 days. In the first postoperative visit, the wife and daughter said, I have been contacted by 7 lawyers to try to sue you. And they said, well, we're not going to do that because we appreciate your honesty. So it may hurt initially when you have that problem, whether it's a complication, whether it's a hernia, whether it's a postoperative infection, but quick resolution of that and the ability for you to be able to move on and that patient to move on has to do with honesty with your patients. I never was sued by that patient, but it brought me angst to know that an intraoperative finding was spread throughout the community in a pretty rapid fashion. Okay, so tell the wife that that is true. How many of you guys would do that? Okay. Ask your attending, now I'm not going to give you the answer, but I'm very interested in your thoughts about what you think the right answer is. Ask your attending why he told the wife his statement. How many of you would do that? I hope all of you. Now I see the fifth years have no question in raising their hand on it. As you go to the interns, I didn't see any hands raised. The level, you have to be a chief resident when it comes to these kind of things. You come to Dr. White and said, why'd you ask that? Why'd you tell the wife that? Is that true? Did you really leave it in? Why didn't you dictate that? Don't be afraid to move forward. Report this to the surgical program director. I guess that's a possibility. Amos doesn't need that any more than I do as chair. The surgeon's responsibility is to make sure that the sponge, instrument, and needle count are correct prior to leaving the operating room. Dr. Rao dictates a beautiful operative note, and at his end, in very big bold letters in his operative note, 3 times I asked the people in the operating room, is this count correct? And indeed, he lets him know that there's a lot of emphasis placed on that sponge needle and lap count. And ask your mentor to address the situation. How many would have done that? That could be an intermediate step. Your mentor should say, you need to go talk to the surgeon. You need to talk to him and see why this happened. All right, so let's move on to the next one. So that's case number 1. Case number 2. A 72-year-old female with advanced dementia is referred to you for a near-obstructing sigmoid mass found on colonoscopy for rectal bleeding. Biopsy revealed adenocarcinoma. Secondary workup showed no evidence of hepatic metastasis on CT scan and a hemoglobin of 12 grams per deciliter. She had no hypotension. She is married to her current husband for 6 years prior to the onset of this cognitive condition, and he is the legal guardian and has consent privileges for his wife. He wants no further intervention due to her overall condition, which is really, other than the rectal bleeding, hadn't substantially changed. Her 2 children are vehemently opposed to this decision and believe that their stepfather has a big life insurance policy on mom, in addition to a new lady friend. He's been hanging around a lot since mother's cognitive condition. As her surgeon, you explained to all the family that she is moderate risk for surgery. I'll show you the lesion itself. This is it, the sigmoid. It is bleeding a little bit, near obstructing. She does have some stools. So moderate risk for colectomy, but it's higher risk for colonic obstruction and bleeding if not operated on. She is discharged and the entire family returns to your clinic together, not in tandem, but together in the room with letters from their respective lawyers. You should, number one, reemphasize to them that she is an acceptable operative candidate from a surgeon's viewpoint and ask them to seek legal mediation. Not sure how long this would take. This could take months to years. Number two, respect the legal boundaries of the husband and discharge the patient, knowing there's a great chance she's going to come back with an obstruction or further bleeding. Number three, ask them to seek family counseling. Number four, tell them that you do not want to get involved and defer any further of this treatment, and basically you wipe your hands of this case. Not uncommon, especially with children who haven't been around family members for quite some time. Classic case, I'm sure the trauma guys have to deal with this quite frequently, is automobile accident. Somebody's not cognitive anymore. All the family come in from around the United States and tell you what you should have done, both medically and legally, and it's just truly a nightmare, especially in people who have secondary gain, either financial secondary gain or pre-existing family problems, and you're kind of caught in the middle of them. Okay, so let's go through each one of these. So reemphasize to them that she's an acceptable candidate in surgery and ask them to seek legal mediation. It's a tough one, I think. Does the husband have legal boundaries to withhold therapy here? He does, that's correct. And you're going to have to respect that, I predict, at that initial setting. You'll need to get legal counsel also by being the surgeon. So it's not uncommon if you're faced with situations like this to call risk management. There's also usually an ethics committee. Since this is not an emergent case, you present this to the ethics committee and see where should we go from a legal standpoint. Should I commit to this case? Should I tell the husband he's doing the wrong thing? Consent means a lot. Taking her back without consent sets you up for legal problems from both sides of the family. I think family counseling may be good, but not probably the primary mode of therapy here. And I think deferring and getting out of the case is just going to kick this can down the road for another surgeon and another problem. So, any questions about this? Dr. Larimore, what do you think? Yeah.
So I might just preface it by, there are some laws that help the physicians with this in Texas, I'm aware of, that you can actually get a couple of physicians to weigh in, particularly if the person is not cognitively able to make decisions for themselves. You can get an independent physician. This is a difficult problem. I think the two, it could be done, but I think I would probably choose number one. I would reemphasize, I would seek them to work it out within the legal construct.
Would that concern you that the mediation may take a year?
Yes, but I think you certainly couldn't operate on the patient without the consent, and you also, I think just saying, I'm not going to get involved in it anymore if that's your feeling, and just have a nice day is probably not a good solution either. So, but it's a difficult problem.
Dr. Warner, what would you do?
Dr. Glenn? Here you go, Mike.
All the above?
I knew you were going to say that.
I think I would not be inclined to operate on this patient myself. I would probably respect the legal boundaries of the husband.
Dr. Gladney?
Here you go, sir. Straighten this off.
I would just have initially a long and candid discussion with everybody concerned, and then do those things that you have suggested, speaking to risk management, speaking to my malpractice attorney, speaking to the ethics committee, and ask the family and the current husband to meet together in counseling. I wouldn't quit.
I agree. Thank you. American College of Surgeons also has white papers on ethical situations you're in, and there's actually a hotline so you can call, say, look, and it's bounded by state law and Louisiana law and even local law for that matter, but you have outside help with these. And it's not like you're in the trauma bay having to make a life or death situation within 3 to 4 minutes. This is something that needs a lot of thought. And I think one thing to do is not enter a debate and try to fix things in the family. Doctors want to fix things. They want to make people happy. When they intercede themselves in between long-standing family relationship issues, it's pretty interesting. I've tried that, thinking, you could soothe things out. Very challenging. Let's go to case number 4. This is a little diagnostic question in addition to an ethical question. It's a 50-year-old male, once again, it's a Jehovah's Witness, with a large gastric mass who presents to the hospital with dark stools and somewhat dizzy. His hemoglobin is 9.2 grams per deciliter, and as seen below, this is the lesion during EGD, and this is the biopsy for H&E stain. I'm not going to tell you the lesion, but you should know this by the permanent section and also just the gross appearance of this. Slowly oozing lesion. You called the gastroenterologist. You wanted to see if we could get endoscopic resolution of this bleeding. It was unsuccessful. Continued to bleed. It was extremely friable. The patient wanted surgery to prevent further bleeding, but does not want homologous or autologous blood or blood products, FFP, platelets, cryoprecipitate. After subtotal gastrectomy, which really went uneventful, it was an open case. His hemoglobin was 6.2 grams per deciliter, and he's hemodynamically stable. The nurse calls the resident about 6 hours post-op. The NG tube was clogged with blood, really wasn't working, and right there while she's talking to you on the phone, expectorated and vomited a large clot. Once again, you scope the patient, you bring him to the operating room, you're scoping again, and you have the gastroenterologist there, and it looks like your staple line is bleeding. His PT, PTT, fibrinogen are all normal. He's normothermic, and he's taken back to the operating room where he is in shock, and his hemoglobin by the blood gas was 4 grams per deciliter. You call the patient's wife, and she says, give him blood to save his life. You should. He had an advance directive. Follow the patient's advance directive and do not transfuse, despite probably a fatal outcome. Number 2, transfuse per the wife's wishes. Number 3, call for a stat ethics consult on the phone, and good luck if you can get those. You can't even get them even electively now. Or call your partners for advice. A little different than someone under 18 years of age, and who, but not totally indifferent in that we're in shock. The decision is so much easier on elective cases where you have the whole family in the room, you give them the options, you try to beef them up with EPO and try to get your hemoglobin to 16 grams per deciliter. It just seems like Jehovah's Witnesses run a hemoglobin of about 10, no matter what you do. And you're going, why? So how many of you would follow the patient's advance directives and not transfuse? Okay. How many would transfuse per the wife's wishes? I thought, okay. Ethics consult, I don't think is a good response, and your partners are going to say, good luck. That's what they're going to say. I'm glad it's not my case. We had, I forgot exactly, I think it was Dr. Song and I had a patient with an aortic dissection who was a Jehovah's Witness, and hemoglobin was about 14 grams per deciliter, and he was on a DOAC for a DVT that he had. So we had to spend about $15,000 on the antidote for those, and the patient did okay, but we rode with a hemoglobin, I think, of about 4.5 to 5 to slowly edged it up to 6, and he got better. Was in the hospital about a month. Okay, good enough. Case 4, we'll go to case 5. Okay, it's a thoracic case, my favorite. You're a senior resident, and you're in the operating room with a patient that has a left upper lobe mass, as noted above, okay? This is the CT scan. It looks like there's chest wall invasion of this left upper lobe lesion. He's got scapular pain, intercostal brachialis pain. This is one of Dr. Gladney's favorite. He and I I made my first superior sulcus tumor together on a urologist's wife. John, I don't know if you remember that. So superior sulcus tumor, neoadjuvant therapy was given, radiation and chemotherapy. There was some EBUS that showed the 4R and 7 lymph nodes were negative, so pathologically there was what appeared to be a Hylar node. So this looks like a T3, T4, NO, N1, MX cancer, biopsy proven squamous cell carcinoma. So you're in the room. He got neoadjuvant therapy. He was scoped before. Go to the net. Okay, what does this gentleman have as far as his physical exam finding here?
Horner syndrome?
You got Samra. It's for the residents. He couldn't hold back.
He
just
prompted me.
He could just not hold back. Okay, mydriasis, ptosis, okay, and hyperhidrosis of that area. Superior cervical ganglion in the apex of the chest. Does not preclude surgery usually. Now, if he was hoarse, that's one thing, but Horner syndrome in its own right is not a contraindication. Neither is chest wall involvement for superior sulcus tumors. When the attending arrives, he goes, okay, get the scope down, let's scope this patient. You perform a fiber optic bronchoscopy that is seen here. I apologize, but this is the true bronchoscope here. So this is in the right upper quadrant is the bubble that's in the right mainstem bronchus. The left mainstem bronchus is this fungating mass that you can barely see air beyond. And you perform fiber optic bronchoscopy as seen here, and compared to the previous fiber optic bronch prior to neoadjuvant therapy, there appears to be progression of disease. You're concerned as chief resident. You want to be a thoracic surgeon. You've done the reading on this case. You mentioned this, and he still wants to proceed with the case. The patient underwent a chest wall resection, a left pneumonectomy, which is really frowned upon after neoadjuvant therapy because of the complications, and had grossly positive margins with the left mainstem bronchus. Not surprising with your endoscopic findings. He has a long postoperative course and dies 6 weeks after the surgery in a rehab hospital. Family's not really happy. You as a resident is not very happy because you're not sure if that was the right operation and should you have aborted. So what could you have done to improve this patient's outcome? So actually this patient probably could have lived another couple of years with the process he had without surgery. Should you have voiced your concern to the attending surgeon about proceeding with the possibility of positive margins? The surgeon's never done a sleeve pneumonectomy. This could have required a sleeve pneumonectomy. The literature is replete that pneumonectomy after neoadjuvant therapy triples the mortality rate for especially a chest wall resection. Number two, review the literature prior to the operation about these tumors and the risk of premature death, and discuss this with the attending, probably there at the bronchoscopic setting. Call his referring oncologist and say, hey, this guy is not doing our patients right. I don't want you to ever send him a case again, which you'll actually, I'm sure, get back to the surgeon pretty quickly. Or discuss this with another faculty thoracic surgeon about this outcome. You're concerned about it. You didn't feel like the right thing happened. And frequently as a resident, you're put in this situation of, what are we doing here? Is this ethical? Or do we know we're going to have a positive margin with a lesser outcome? That's why I think it really behooves you to know the literature when you set foot in that operating room, whether it's a melanoma, whether it's an advanced colon cancer, whether it's a robotic versus open cancer, and question authority. Ask questions. Hey, what do you think? And you can do it very professionally. What do you think? You think we can get this out safely? Are we going to have to do a sleeve pneumonectomy here? Some of those questions could potentially change what goes on the next step. Believe it, because it happens. So, number one, who wanted that? Okay. In your review of the literature, another thing to do before a big case like this, and we did in thoracic at Salt Lake City, is when we had a case like this, the attending would frequently sit us down and say, look, this is going to be tough. I may have to do a little bit of the case, or a little bit more than I usually do. So to give the resident an idea of the scope of the operation, what's going to make us turn back, what's going to make me have to do some of this case, and get that done the day before, because there's a lot of tension and stuff in the operating room. Those little pre-op discussions are very important, and I think they're good to have. The tumor conference can't ameliorate all the stress that's going to happen because some of the intraoperative findings may not be brought out in tumor board. I think the tumor board is a crux that we use sometimes to say, wow, they said I could do it, so I'm going to move forward. I think that's not, a lot of these decisions are intraoperative, so just because a tumor board says proceed as planned, yeah, maybe not a hemicorpectomy, okay, things like that. You have to use your reason and decide what's the right thing and what the wrong thing is to do. So review the literature. It's very important to know what the contraindications to surgery are when you get in there. Okay, if that person is hoarse and you're concerned about level 5 and level 6 nodes in the mediastinum, So why are we doing this? Can you help me understand? Okay? Please listen to that. Okay. Tough case here. This is a theoretical case. You're a senior resident in a redo aorta biofilm with your vascular surgeon for an infected graft. There's air around the left limb of the conduit, positive blood cultures for staph epidermidis. The attending calls into the room and states he's running a little late and asks you to get cranked up with this lap, which you found a little odd. It's a redo laparotomy, a big case. The scrub nurse is a little nervous. The timeout's called. The attending's not there. She says, and you make her feel better, I'm just going to get through the incision and take some adhesions down. So you start the case without incident, start taking adhesions down. The attending joins you on the assistant side when you notice that he's impaired. He's slurring his words. Something is just not right, and you can smell some alcohol. The most appropriate mode of action is, number one, ask if you can speak to him outside of the room by the scrub sink prior to proceeding, and then ask him about his status and how he wants to proceed. Not too late to abort the case. Number two, take the electrocardiography instruments from him and intervening, stating that this case cannot proceed. That's happened. Number three, break scrub and go directly to the chairman's office. Sometimes could be construed as abandonment of patient. You are the fail-safe mechanism there. Stay in the room. Ask the circulating nurse to call the CMO, which would be me, of the hospital to come rectify the situation. Luckily, we haven't gotten any of those calls. Tough situation. Okay, number one. How many of y'all would do that? You got to do something. You got to do something then. You don't want to take the electrocardiography. You don't want to be confrontational. The nurses will get an idea when you step out to the scrub sink. Now, what the more difficult question is if he doesn't concede and want to go outside, and the operation continues. And you're sitting there, you're about to get down to the graft, things are getting hairy, and you just said, I just can't do this ethically. I think then you move forward and talking to scrub techs to get somebody else in there, and then you can talk to them as things go on. Now, what if you're wrong? What if you're wrong? I still think the safety of the patient is first and foremost, and I think nobody would, you may take some heat, but number one, you're erring on the side of safety for the patient. Okay. And last case, you're a newly hired surgeon after your MIS fellowship, and you've been consulted by the gastroenterologist in your medical group. Y'all are in a closed health system, but you're still competing with your partners to get these great robotic cases that you're so adequately trained to do. For a locally advanced right colon cancer, so it looks like a T3N1MX. It's a 72-year-old morbidly obese male, has had a robotic anti-reflux procedure in the past. I had a Nissen fundoplication. The referring and the patient makes it very clear, this is your second month in practice, that they want a minimally invasive operation. What do? Proceed without hesitation since you had a great fellowship. You are ready Freddy. Okay, redo case, morbidly obese, sounds like a technically very challenging case. Number two, ask him to refer the patient to your senior partner. Real break to your ego here. He does a few robots and you've done 300 or 400. Patient, you can start with minimally invasive, but there is a substantial chance because of your inexperience, and you have to bring that. They're going to ask you how many of these you've done, that you will have to convert to a laparotomy. And he's not happy and may ask you to refer him somewhere else. Or, lastly, ask your senior partner to help you with this redo robotic case. Go ahead and write your answers down, and then we'll query everybody. Okay, number one, what do you do when you're just not sure how to proceed? Number two, some people would do that, and I think it's acceptable, because what you could do is scrub with your senior partner and get some experience on this. What you don't need is, a 75% conversion rate your first 2 years with robotic cases, because your new partners are going to say, wow, he got MIS trained? What are we doing here? You have to select your cases when you first get out. And it's okay to say no. It's okay to take part in the case, but it maybe as an assistant. Tell the patient that you can start with minimally invasive, may have to convert, get a chance to do the case and still be able to bail. Or ask your senior partner to help with the robot case. Who wants to do that? That's what I would do, for sure. It's okay to call your partners. It's okay to do things that you feel are going to be very challenging. And I think that's it. We'll grade those. I hope only you just answered 4. If you didn't, oh, I'm sorry. I got one more. I'm sorry. One more case. Sorry, Sam. One more. This is a good case, too. Okay. Thought I had 6. I got 7. You've been consulted in the ED. This is a very common case that we've discussed in M&M. You've been consulted in the ED for an 86-year-old female who was found down in her assisted living area. She was intubated at the scene, was given 2 liters of crystalloid by the EMTs due to persistent hypotension. She is arousable, does not follow commands. She moves all 4 extremities. When you arrive, her blood pressure is 90/50. She's an AFib with rapid ventricular response, or moderate ventricular response, with a heart rate of 122, and she's on low-dose norepinephrine. Her white count's 32,000. Her creatinine is 3.4. She has normal troponin, and they put a Foley in, and there's no urine. Her lactate is 16. We all know that's huge. CT of the head without contrast shows no abnormalities. They did not do IV contrast in her abdomen. It shows pneumoperitoneum and mesenteric stranding. You ask the family about what her condition is at the home, and she is bedbound, but very awake, very alert, and visits with her family quite frequently. They want everything done. You should increase the norepi and proceed with laparotomy. Consult the ethics committee again. Tell the family that this is a futile operation with little chance of survival and ask them to reconsider. And lastly, tell the ED and family that you will not proceed due to its futility. And think about this and write your answer down. Tough case. Frequently, with thoracic and Dr. I don't know how many cases Dr. Verk has done, has had similar cases just like this. You know, how far do you go? What do you do? Is it a futile case? What are they going to say in M&M? Is the family in agreement? What's my chance of a good outcome? There's a lot of predictors here that this patient's not going to do well. And you have right legally to turn the case down. Now, you have to seek consultations, but nothing leads you that you have to operate on patients that you think are going to have a bad outcome. That there was I think a recent American College of Surgeons bulletin on futile cases and your response as a surgeon and your rights as a surgeon to make sure that you have good outcomes. And there's some legal precedents behind that. Okay, so who would increase the norepi and proceed with laparotomy? Okay, I knew that. Garrett, I knew you were going to do that. That's good. Yes. Who knows? It may not be anything, maybe a perf divertic, right? It may not be dead bowel like you're all thinking. Atrial fibrillation, high base excess, is there a chance you can get this patient through? So I think operating is a viable option here. The statistics say otherwise. Tell the family this is futile operation and little chance of survival and ask them to reconsider. Anybody with that one? Okay. Most people in the room would say that. Or tell the ED that you have this option to say, I just can't do this case. I've done that with dissections with malperfusion. People come in with dead bowel, with a type A dissection, and they're in their 80s or 90s, and I say, look, I don't think I can get this patient home. I can operate, maybe fix it. The chance of your loved one getting to the house is virtually zero. If they want you to proceed, and I think you need to use numbers, try to get a good estimate of what the chance of a poor outcome is to let them know that. So this is going to conclude our question and answer session for this. Good luck to all you. I hope you all win the money. And if there is ties, I guess I'm going to have to belly up and get some more money for you guys. And that's what Venmo's for, right? So we're going to take a break. What do you think? 15-minute break, or what we're going to have here? Okay. Okay, let's see at 10:15, and I'll start with my lecture, and we'll go from there. Hey, Amy, is this working? Oh, okay. Oh, my goodness, thank you. Let me see if I'm just trying to get the next slide. Oh, there we go. There we go. Good. It does, thank you. Kevin, I'll ask you about some of this historical accuracy at the end of this now.
It's accurate.
All right, I guess I'll get started so we can get things cranked up, going up. Did y'all think the last session was useful? Dr. Richardson brought up a good point. I think maybe a family feud type of protocol next time where we pick your teams and go to town on some of these difficult questions. It should be a fun day, not a stressful day. This talk started probably 7 years ago. Dr. Grimes is in the back of the audience, and he and I would have jam sessions like musicians do, just talking about good old stories, good old-fashioned history of this program. And I think the thing that Carolyn Song came to me, she was having some issues at her second year, and she heard this talk, and she was, Dr. White, I want you to know I didn't know what our lineage was. I didn't know the history of this program, and I am so proud to be involved here. So if I can reach you at that point of your life and part of your career, that this place has a great and a grand history. Like a lot of Louisiana programs, there's a lot of color. Chicanery, political favors, typical Louisiana politics. But at the heart of the matter, we've taken care of millions of people who had nowhere to go, absolutely nowhere to go. So one of the reasons that I came back here is to take care of poor Louisianians. To be honest with you, I just thought it was part of my being, my well-being, the things that I wanted to contribute to medicine. Obviously, I love to do surgery. I love to do complex surgery, and there's plenty here. But this talk really focuses in on where did we start? When did the Department of Surgery actually have its being, its start, its origin? And it's well before it was called LSU. It was well before it was American College certified. It started at a very early time period when Shreveport just had its beginnings. Number one, it started of a community with a very strong medical society. It was called North Louisiana Medical Society, which merged into Shreveport Medical Society, which is now Northwestern Louisiana Medical Society. But that is the thing that really kind of brought surgeons together and made us a tour de force in Northwest Louisiana. And Shreveport was the epicenter, and you'll see by the number of hospitals in 1930, was the epicenter of surgical training. It was the epicenter of technology in this area. It wasn't Dallas, it was Shreveport, and you'd be surprised at the number of applicants we got for the Shreveport Charity Hospital internship and surgical residency program, well before the American College got involved. So where do we begin? We begin at the start, and that's when surgery really started here at LSU and when we started teaching. While there was not much of a delineation between family practitioners and surgeons back in the late 1800s, early 1900s, things morphed at a very rapid pace because of some leaders in Shreveport, Louisiana that made this program extremely volatile and extremely, it morphed to the times that needed to be done at that time. So we're going to start at the very beginning and we'll finish at the end, like they say. So to know the Shreveport history of why Shreveport all of a sudden became the epicenter of healthcare, you have to know its start. And that was back in the 1830s. Captain Shreve was hired by the U.S. government because there was an impasse on the Red River. This was before rail. And it was a major hub. Red River was a major hub for shipping before rail. and it had a lot of economic consequences to the northwest Louisiana, and also military implications after the Civil War. So Shreveport was basically just a cow town before that. It had to have the river to be volatile, and it had to have the river to survive in the community at the late 1800s. So there was this 110-mile raft. The Great Raft is not just a bar. It actually happened in history. This is the vehicle that Captain Shreve used. It was steam-powered, obviously, had these huge arms that they could pull stumps out and rid of this 110-mile raft that was present in northwest Louisiana. 110 miles where you could not pass. That's where Cross Lake formed because of the estuaries that formed to the north of this. The water had to go somewhere, so Pierre Bayou, Cross Lake, the things you see now are vestiges of this raft. So when it was cleared, Shreveport really started its history. The Atchafalaya Basin also had a raft in South Louisiana. Captain Shreve didn't go that far, and they had to hire, I think, someone from New Orleans. But this raft truly made navigation it held at a standstill. So 1936, the Shrevetown Company started with a bunch of investors. They saw that the raft had been cleared, that now you have steamships rolling at an unprecedented rate. You had tens of thousands of people moving into Shreveport that needed health care. So Captain Shreve never lived in Shreveport, actually died, I think, in Louisville, Kentucky, but made a huge impact, and thus his town holds his name. It's a very busy port, and between 1865 and 1872, 221 steamboats with approximately 20 tons of cotton, of corn, of all the things that were being produced in northwest Louisiana to be shipped down to New Orleans, which was obviously the great port, and 63,000 people came through. This town was a wild town back then. If you look at some of the early history, there was a lot of saloons, a lot of penetrating trauma, a lot of blunt trauma, and if you look at some of the trauma numbers, you would be really surprised at the number of gunshot wounds that were taken care of at a very early portion of this city. Dr. Ambrose Clark was the first doctor that was described, not a lot written about him, but he is written as the first doctor that really started things over here. North Louisiana Medical Society in 1950s preceded the hospitals. Most of the hospitals were people's homes, where people would go either here or there, normally right near the river, where they could get health care, usually from a physician that was not licensed, of course, never went to medical school, and basically took this on as a trade. Many of the early physicians were farmers, planters, and militiamen from the Civil War. As a matter of fact, Dr. T.G. Ford, one of the first surgeons here, was a Civil War surgeon. They relocated for Louisiana, not because they wanted to come here to practice medicine, but because there was huge amount of resources in farming. It was agricultural, and that's why they came and used their profession that they had learned elsewhere to make them successful. They started treating neighbors, they formed coalitions, and another thing that you would think separate people, actually bonded people, was the yellow fever epidemic that was in that time. And we had 3 of these that killed roughly 1,000 people in Shreveport over 3 yellow fever epidemics. You look at some of the early hospital architecture, there was mosquito nets, not only here, but Charity in Old New Orleans had similar mosquito net hooks where they used this to prevent the mosquito infestations there. So some of the first hospitals were basically people's homes. We see in the newspapers, and this is where I got a lot of my data from the old Shreveport Times that has a grand registry that you can look through online to get some of the information and some of the clippings I have here. Also, the Knoll Library over at Shreveport, and also our own repository here that has a lot of historical data. So, there was an appropriation made for Shreveport Charity Hospital back in 1872. This was only about 30 years after the city of Shreveport started. So no bonds were sold, the governor wouldn't sign the signature, and you're going to find that is a recurring theme, that North Louisiana got left out of a lot of appropriations, and they tended to sign bills that were concentrated south of Alexandria because that's where the population base was. But the first Shreveport hospital, as you can see here on this map, this is the very first hospital in Ledbetter Heights. You wouldn't even visit there by car today, but this was actually a very beautiful, flourishing pasture land that had some natural springs. It had, the first hospital was a log and frame building, and it was a site of previous schools. and that's where the first building was. There was only about 3 doctors. There was actually a surgical intern and a medical intern. So the first 2 doctors that were in training actually happened in 1876. That's why you'll see a lot of these numbers start in 1876 to present. During the yellow fever, a prostitute donated her home. That was another hospital that kind of independently formed. There were 17, 18 patients that were treated there. The Howard Association, along with the Mercy Association, were 2 African-American hospitals that held 15 to 20 patients. The Marine Hospital was actually formed by the U.S. government. You can't find that in the archives of the feds, but it is noted here in the newspaper and some of the archives that because 60-some-odd thousand people were visiting here, we had to have health care. So the government started this hospital and later to be known as Shreveport Charity Hospital. First trained nurses were in 1899. And this is the official notice in the Shreveport Times in 1872. The Shreveport Times started about 1865. It shows Charity Hospital at a meeting of the Board of Administrators. Mr. Turner, Stoner, Jacobs, and Leonard resolved a lot of things. And they sent this to Baton Rouge and got absolutely no money for a course of about 10 years. So the challenges were repeated requests from Northwest Louisiana about the need for charity hospitals. If you look at the history of our hospital today and those hospitals in the 1870s, the city of Shreveport and Caddo Parish never donated a single dime other than maybe free water. This was all state funds, and even now the state funds have diminished with the addition of Ochsner. But back then, Shreveport once never really paid for the health care here, and they probably shouldn't have. But this and 10 other hospitals that formed in the charity hospital system in Louisiana were strictly funded by the state of Louisiana, and in their charter was for indigent patients only. So there was a lot of controversy early on. Could you bring a private patient to Charity Hospital? And Dr. T.E. Shumpert got into a fight with the board that I wanted to bring private cases here. And there's one reason why he left after 7 years as a professor and the chief of surgery at Old Charity Shreveport, is that he wanted to bring private patients in and bring money into the system. They wouldn't allow it, so he built his own hospital. It was quite successful. But we had fire hazards. We had no morgue. We had capacity in 1888 of 68 beds for thousands of patients who wanted to get in. It had to be left at home and couldn't get operating care and couldn't get surgical care. They had a pest house where people with communicable diseases had to be taken to this 17-bed pest house, which basically had no air, had no water. It was basically a place to die where people with advanced tuberculosis and infectious diseases were sent. And once again, there was controversy about patients who had had money or had no compensation at all. Could they be admitted to the charity hospital system? But the hospital that we know now as the first major hospital over 75 beds was at the corner of Texas and Murphy, where the police department is right now. 1904 is when it was built, and it looked like this. This is a rendition. This was actually an old photograph that shows the rail car, which was functioning there. There's some horse and buggies you'll see on another picture, but right in front of Charity Hospital to drop off the sick and the indigent. This hospital only held about 60 to 70 patients early on, but went up to 400 beds over the course of the next 20 to 30 years. Just a little bit finer picture. It shows Charity Hospital, and as you'll notice, as was the fair in this time period, that there are symmetrical buildings. There are usually 2 wings for African American in this area and for the Caucasian and non-African American in the other. You look at Emory, you look at LA County, you look at Cook County, you look at some of these hospitals were built in the 50s, 40s, 50s, and 60s during segregation, that they were all built with a kind of a mirror ward system so they could segregate the patients. And obviously it doesn't, and thankfully it doesn't hurt, it could continue to go that way. So the new Shreveport Charity Hospital was built in 1904, 180 bed capacity, 6 furnished wards. There was a training school for nurses. It was built right across the street on Murphy Street. We had about 600 patients a month early on, a lot of trauma. We have 11% of trauma patients now in our census. They had about 15%. So the amount of trauma patients has not changed significantly in over 140 years about what constitutes our daily average census. We had 29 cents per patient is all we got from the state of Louisiana, and you can imagine the deficits that rolled up. And there was a huge fire in 1926. There are 215 patients had to be transported out of Charity to local areas so they could be safely taken care of, mostly in other people's houses. And we added on for 454 beds. 454 beds. And there was no screens at that time. The hospital wasn't screened for another 10 years, but there was 300 fly swatters given out to all the patients, and they were used, I can tell you. Shreveport had a love for their charity hospital, and this was before private hospitals started. T.E. Shumpert was the first private hospital, the North Louisiana Sanitarium that he built, and went on to be the great Shumpert Hospital of Shreveport. But the affluent people in Shreveport wanted a charity hospital here. They wanted the indigent to be taken care of. They knew the indigent went there. They had a big heart for the people who came to Louisiana on the steamboats, the transients, the poor, the people who had nothing else to go to. So they, in the paper, when the state of Louisiana fell short, they really pushed forward in the newspapers and all the communication they could to get money. They had fairs, they had an opera house, and all of those, the monies that from those events would go into helping Charity Hospital, adding on wings. And it was not like you see today where a person's name is added on to the bed or the chair or the wing. This is all anonymous giving from the city. And they called Charity Hospital the city itself because there were so many people in and out of there. Money was desired at the state level, and frequently we were turned down. These are the locations of the charity hospitals as historically was correct. This is at Ford and Pierre Street in Ledbetter Heights. We talked about that earlier. And here is Texas Street and Murphy Street, where the original, in 1904, the original Shreveport Charity Hospital. This is a little bit better color. This is, you can find a lot of pictures in old history in Shreveport by postcards. People would photograph that, make postcards, and send to their best friends. I'm not sure who wanted to send a charity hospital photo, but they did. But it had two beautiful fountains. Once again, was right in close proximity to the rail cars. Dr. Randall Hunt was one of the first early chiefs of surgery. Now, this is 160 beds, and this is the people who ran it. Talk about a difficult nursing ratio. So these are four medical interns and two surgical interns. Dr. Hunt in 1904 was the chief of surgery, and these are the nurses that took care of him. Now, there were a substantial amount of trained nurses that were in training, about 50 or 60 that would help, but this was the manpower in that big hospital in 1904. Similar picture in the Shreveport Times here. This is the new iteration that was rebuilt a few years later because of pestilence, because of leaks, because of fires, and because they just didn't have enough room. They were bursting at the seam. And this is the new hospital, once again, with 4 wings, and these are all the people that worked there with the addition of the new wings and the addition of some more manpower. There was, once again, a fire at the charity hospital that had to be evacuated, which unfortunately happened, but fortunately happened that this place needed to be rebuilt, and it was successfully to help the poor of Louisiana. This is it in an aerial view, which is pretty rare back in this time, but it shows the concurrent symmetrical wings for the Caucasian and the African American population. The nursing school was here, and they actually built a tunnel from the residents' dining room for some reason all the way to the nursing school. So it's an aqueduct that was filled in, but this aqueduct ran from I bet there was some shenanigans that went on there, but you never know. But they had a gymnasium, they had tennis courts, they had a lot of things to keep the residents were not allowed. This was a lot of their housing. They lived here for several years. But once again, the nursing school's in close opposition there. This is one of the operating rooms in the old Charity. Big doors, big lights, no headlights. And as you'll see, this was probably the first bullpen. This is actually a patient that's being presented to some of the local physicians. This is the patient here. Not sure who this is, but they're in the proximity of the operating room. A lot of the teaching happened in street clothes in the OR. And you'll see some further pictures of, I'm not sure where they got their sterile technique like this. Here they are in the middle of a trauma, brachial artery injury, and this lady has no mask on. She has no mask on, but they are operating away in some cavity. So what are some of the other hospitals? You know, we talked about Shreveport as a huge epicenter for healthcare. The recurrent theme at LSU is that the doctors are hired here, trained here, become very successful here, then they move into the private sector and become equally as successful. If you look at the number of doctors in Northwest Louisiana, 85% have trained at this institution at one time or the other. Dr. Shumpert probably has the most notoriety as far as his name, was at LSU in the late 1800s for about 7 years. He got fed up with it. He couldn't bring his private paying patients here, so he got all out of here pretty quickly and basically ran his own sanitarium. It was called the T.E. Shumpert Memorial Sanitarium, initially the North Louisiana Sanitarium. Dr. Lewis Abramson and Dr. Paul Abramson, dad and son combo, started the North Louisiana Sanitarium. That's where the Willis Knighton Rehab is. It used to be an old hospital that ended up also being named Physicians and Surgeons. Highland Sanitarium is one of the oldest hospitals here. It's still in its original location now as Brentwood, I think, is what they use, and they've had some additions on. But beautiful place, and if you look at the newspapers, they truly had some of the state-of-the-art medical equipment there. Tri-State, Willis Knighton, the same location it was in 1926 when it started. And the war between LSU and Willis Knighton continued and even started in the 30s, and I'll show you some examples of that. Shriners Hospital, the first Shriners in the United States, was one of the second or third hospitals here, started by the El Karuba Temple. It cost of $450,000. And little known to most people is that we had a sanitarium on Greenwood Road that treated thoracic tuberculosis between 1914 and 1968 when medical therapy of tuberculosis was carried out. There was a thoracic residency program until 1961 where they trained 2 thoracic surgeons here in a fellowship-approved fashion at the Pines Tuberculosis. A lot of massive hemoptysis, empty spaces, just a ton of things. And they had about 60 to 70 beds that stayed 100% acquired or 100% full because of the tuberculosis in that time period. It was taken over by Charity Hospital in 1948. We tried to move it here to Shreveport, or I should say inside the Shreveport Charity Hospital, but that was turned down by the board. Sorry about the picture quality here. What you see is the Shriners Hospital, definitely not the same hospital we have over there now. T.E. Shumpert grew on Margaret Street, and if you look, also a recurring theme is that the big hospitals place themselves at the highest portion of Shreveport's altitude, highest of which is about 250 feet, but nonetheless it kept them out of the mosquito doldrums and the bottoms, they used to call. It's where typhoid, yellow fever, and other bloodborne bacteria and bloodborne diseases came. So the best hospitals were in the highest places of Shreveport, and that includes Margaret Place, which is where St. Mary's is now, and also the First Charity at Texas Street and Murphy Street. This is Shreveport Charity, which you really can't see. Highland Sanitarium hasn't changed the architecture much since that time. North Louisiana Sanitarium by the Abramson, and also Tri-State, which is the early onlog of Willis Knighton. So as time went on, the hospital on Texas and Murphy basically just ran out of space, ran out of monies, and there was kind of a community get-together on how can we build a new hospital. Well, where our hospital now sits came about not through so much from state funding, but by a huge amount of money from the Confederate Wives Association. So the wives of the generals and the militiamen who fought in the Civil War had a huge amount of savings that had accrued a lot of money into the tens of millions of dollars, and this was used to build Confederate Memorial Medical Center. Obviously not a name that we would not use today, but nonetheless had integral meetings to where the monies came from. And they asked to be named this because of that. So 1953 is when this hospital opened. A nursing school was built a few years later, about 150 feet from the hospital, and this is the nurses. They had suntans up here, they played badminton, had parties. This is the administration building that we all walked through, headed toward the new medical education building at that time. So how many beds did we have? If you look at the inpatient numbers, from 1900 to 2024, this shows the number of inpatients that was at either Shreveport Charity, Confederate Memorial Hospital, LSU HS, which is our current facility. We were a behemoth compared to some of the other areas in the southeastern United States, and I'll show you that in just a moment. But this shows the number of inpatient beds. Now, medicine changed around 1960 to 1970, more outpatient procedures, so you'll see that dip. But look at the meteorical rise that you see in inpatients in this time period, especially 1930s and 40s, especially after World War II. And there, after World War I and after World War II, there were very few interns and surgical residents here because of the need to have manpower in Europe to assist in the Allies. So this is the inpatient numbers that you see here, and this is roughly what we see today. So why is the number decreased? Well, more outpatient procedures, and you don't stay in the hospital for a myocardial infarction for 3 weeks. Patients are in and out quicker. So how did that equate into the number of beds? At peak, this hospital had 880 beds. Today our census is 230, mostly because medicine's more efficient. But can you imagine having 120 patients on your general surgery ward? And that's what 3 or 4 residents were taking care of, along with 3 or 4 nurses. And they got it done. They really got it done. But the number of beds in full capacity, insurance was paying out the wazoo, nobody got denied, everybody had money, and Medicare was, while vehemently opposed initially, became the mainstay for reimbursement. This is in 1948, I believe. If you look at the number of beds, look at Cook County, 3,300 beds. Charity Hospital had over 3,000 beds. But Little Shreveport, in number 23, 888 beds. We were a huge behemoth hospital at that time. Took care of a lot of cancer. There was tumor wards. There were, obviously not a lot of plastic surgery at that time, but there were huge trauma bays. There were huge trauma services at that time. And we were in competition with monies from Louisiana, from Huey Long, who didn't necessarily favor his portion of the state. He's from Winfield, but didn't fund a lot of money unless you had some sort of political connection with his machine, so to speak. This is Dr. Vadrine, who ran Huey Long's hospital at Charity in New Orleans, which opened after his death in 1935. Dr. Vadrine was from Ville Platte and was not the most talented surgeon in the world. And when Huey Long got shot by an ENT resident at the state capitol in 1935, he was calling the people who he knew were excellent technicians. Alton Ochsner, Dr. Sanderson, who was here at Shreveport. Unfortunately, the only one who was there at the state capitol was this poorly trained surgeon from Ville Platte, who was a political crony, but was afraid to operate on the governor, operated on him, and missed a large renal hematoma. There was a small colotomy colon perforation that he fixed, but he did not want to explore the right perirenal hematoma, and it continued to expand. So they closed him after about an hour of operating. He died about a day later after multiple transfusions. A urologist came in, put a catheter in, there was frank blood, put a big needle in his retroperitoneum and got frank blood. So there was a huge retroperitoneal hematoma for the governor, and he died from that because he did not have the right surgeons. He had his political cronies, but didn't have the right person in the operating room who should have been there to take care of him, and subsequently succumbed because of that. This is Huey. Loved to lead the LSU band, went to a lot of away games, and whether you loved him or hated him, he was the most powerful man in Louisiana political history and did a lot of things for the charity hospital system, especially in New Orleans. This is the Miles Auditorium down in Charity. There's 2 auditoriums, one for the Tulane side and one for the LSU side. This was the Tulane side. So we're going through this in kind of a fashion of where we talk about places, then we'll talk about people. But as you well know, Shreveport had one of the biggest charity hospital programs in the United States and was one of the last ones to privatize outside of West Virginia. I won't go through all these charity hospital systems, but these were all basically supported by the state of Louisiana. And they weren't funded like they should have been. It's very expensive. The reimbursement was obviously exceedingly low, and there was a lot of pestilence, a lot of infectious diseases, and a ton of trauma. 3 medical schools, and about to be the 4th medical school, which will be Xavier, which will be opening in a few years. But Tulane was actually the first medical school, 1834. LSU New Orleans in 1931, prior to Huey Long's death. And then we started as LSU Medical Center in 1965, although we had been training surgeons for 100 years prior to that. This is the gown and town group. So you have people from the gown or from the town come in with their suits, and sometimes we would call them the suits on Tuesday mornings when they made rounds with Dr. McDonald to come in and watch an operation. To hell with sterile technique. They're going to watch this operation, which is going on right here. So hopefully this was not a laparotomy or a thoracotomy. Maybe it was something local, but this is actually from the archives on what happened back in the 30s, 40s, and 50s. So Confederate Memorial transferred to LSU in 1976, and it's gone through several iterations. If you look at all the names, we know all of that. Louisiana really wanted to kind of divert the responsibility of this huge mega charity system and try to get it out. It was very messy for the politics. It was very messy for the budget. And so they tried to divert this, and they finally, LSU ended up with almost all of these charity hospital systems as they managed them. Big headache for LSU likewise. So as you'll see in later slides, in 2013, the governor wanted to privatize these hospitals and get the Louisiana charity systems out of the budget, which he did successfully, and he was a pariah for that at that time, but I think it's going to be the best thing that's happened for our system to not have the state of Louisiana for that. Now we're going to go over some of the people. There's 27 chairs. This took a lot of research because when you get back to the political favors that were being passed on, the superintendents of Charity Hospital, who was the chair of surgery, it took probably 3 months to find all these names in a fashion of how they contributed to our Department of Surgery. And I say that loosely, not the LSU Department of Surgery, but LSU Surgery. And I have highlighted who I think are the biggest contributors. Obviously, I didn't know a lot of these. Some of this is from history, but some of this is, when you get into the 50s and 60s, from some verbal communications between people who knew some of the surgeons. Dr. T.G. Ford, which we'll go over in a few minutes. I won't go through all these names. Dr. Hunt, you saw in the picture. Dr. Hendricks actually went on and started Highland Hospital. Dr. Charles Rue, Dr. B.C. Garrett, a lot of these were vascular, thoracic, and general surgeons. They did it all in addition to pediatrics. Dr. J.C. Willis was one of the owners and progenitors of Tri-State and went on for Willis-Knighton. Dr. E.L. Sanderson was quite a character, and I'm going to kind of extrapolate on some of the things he did, made this a very strong surgical program. Had about 12 surgical residents, which back then was a huge number. He was quite a character. Dr. Brown, Dr. Wallace Brown, I met a couple of times. Dr. Gladney knows real well, was probably the consummate, one of the best technical surgeons, all of about 5'2" of him, but one of the best technical surgeons I had ever seen operate. And then Dr. Hurd. These are some of the names that you'll notice on the pictures on the north end of the Department of Surgery. Dr. Abramson is the name of today's conference is named after him. Dr. Charles Black, his son worked at the VA for quite some time, Charles Black Jr., but Dr. Black was pivotal in the start of the medical school here at LSU Shreveport. Went to the legislature and had a huge amount of impact on starting the medical school. Dr. Charles Knight, who I know personally and know all of his sons, was huge in trying to bridge the old-fashioned charity hospital to academic health and academic surgery when John McDonald started back in the mid-70s. Dr. John McDonald and Dr. Kurzweg, who was his progenitor, but Dr. McDonald, you can't say enough about him, and I have an era of surgery named after him about what he did here, and I'm always amazed when I look back at how he propelled this place into notoriety, what he did, and the manpower he had. Dr. Turnage, Dr. Ben Lee, Dr. Kevin Satig was here. Sorry, Kevin. It was an interim here in between Dr. McDonald and Dr. Turnage. Dr. Dean Griffin, we all know and love. Dr. Jane Eggerstad's never mentioned, but she had a huge role in me going into cardiac surgery. Once again, just a great woman who loved this, was here for 30 years in medical education, and did some great training at Boston Children's, also in Toronto. could do congenital, adult, thoracic, and she knew all the big names that taught her. And Dr. John Owens was here for a year, and yours truly. So Dr. Ford was the first surgeon here because he had actually cut off more extremities in the Civil War than anyone, which made him the most qualified surgeon. Intra-abdominal surgery back in the late 1800s was very, very mortal, I should say, because anesthesia techniques, you were just likely to die from surgery, die from the anesthesias you were to die from the operation itself. But did what he could do with a minimal amount of hospitals and care, advanced care that he could do. Unfortunately, he went to prison. His wife was an adulteress, and he tracked his wife's lover down in New Orleans in a bar, shot him 3 times, not once, but 3 times, and went to jail, went to prison in New Orleans, and basically was pardoned because that was justifiable homicide in those time periods. That if someone was a lecher, someone was an adulterer, you had every right to shoot that either the spouse and or the lover. So he got out. So once again, the history of Louisiana precedes itself. Once again, Dr. Shumpert we talked about. Thatcher was a private institution here in Shreveport. He went to LSU, Louisville, NYU, and returned to Charity. He ligated the first subclavian artery for aneurysm at Charity Hospital here, the first vascular case that was done here. Dr. Mattis visited here at Charity Hospital because he wanted to know what the secret was of Shreveport getting all the interns and surgical residents. Nobody wanted to go to New Orleans. So he came up here to look, and I think this was in the 1930s, 1940s before he passed. But he found that Shreveport was a special place. People liked to come here. There was plenty of trauma, plenty of operating in a kinder and milder setting than New Orleans. But he made a trip up here and was actually the father of vascular surgery. Dr. Shumpert died of typhoid fever at 47 and gave his entire money to the Sisters of Charity to build Shumpert Hospital on Margaret, and it took off after there. It was one of the most successful hospitals in this region. Dr. Hendricks formed Highland Hospital as we spoke. Dr. Sanderson, this guy was something. He was here. He ruled this place with an iron fist from 1928 to 1940. He was a politico. He was a personal friend of Huey Long. And when Huey Long made it to senator out of the gubernatorial chair, he asked Sanderson to run for governor. So we had a department chair here who was potentially going to be a governor. He got into a lot of trouble, though. The problem with that, he tried to make some of the nurses, he made them promise that they would vote for Earl Long, Huey's brother, and got in a lot of trouble for it. He kind of started the gown versus town. He and the private physicians just didn't jihad. A lot of fighting. He beat somebody up at Shumpert at the hospital for taking one of his patients, and he sued Dr. Willis and Dr. Allens at Willis Knight for an article they wrote in a crime magazine. And he hired almost half of his family to the Charity Hospital system. Quite a good-looking young man, very successful. The women loved him, the nurses loved him, but he got in a lot of trouble. He was technically very astute. He fixed the first heart wound here, penetrating wound to the right ventricle. He put 8 stitches in Willie Neal's heart, and the patient survived, which is almost unheard of in the late 1930s. Then he fired a surgeon for doing the same operation without calling him. So he fired, this surgeon was let go because about 3 months later, the surgeon did the exact same operation with the exact same outcome. Dr. Sanderson came in and said, "These are my cases. You didn't call me. I'm the superintendent of the hospital and the chair of surgery," and fired him on the spot. So once again, things surrounded him that should not have. He sued 2 Willis Knighton doctors in 1930s for writing an article in this great detective magazine. I've got a copy of this, believe it or not, and it talked about, inconspicuously, but made tendencies that this was LSU Shreveport about how it handled people who had passed away, that there was a money scheme behind it. So this was a great detective story that Sanders got a hold of, and he sued these Willis Knighton doctors. Well, the judge said, "I'm just not going to sit here and run this. This is a circus. I want you guys to settle in. They shook hands, went their separate ways, but once again, surrounding himself with some very interesting stories. He tried to start a sanitarium. This was going to be a 800, 900 bed sanitarium here in Shreveport. Sanitarium was a great name for a hospital where you go to get taken care of. It sounded cleaner. People went to hospitals to die. Sanitariums were there for health, obviously. He tried to gain bonds to build this huge sanitarium, and it failed. And this was kind of the beginning of the end for Dr. Sanderson. Made threats to nurses. If they didn't vote for Huey Long, he was going to fire them. Obviously, he said that's not the case, but once again, was mired in a lot of controversy. And Dr. Sanderson cut his glove during an amputation for sepsis and almost died of sepsis himself. After that, he retired and he said, I've had enough of this. In 1940, he retired from LSU, went into private practice, and died of a myocardial infarction roughly 5 years after that. Dr. Joseph Hurd is the first picture to the right near my office. Most of these were Tulane grads because LSU didn't have their medical school at that time. Dr. Paul Abramson, who we've discussed before, a real stand-up guy in the community. And the first Abramson visiting lecturer was Dr. Dean Warren. You may not know that name, but the gray hairs in the audience do. The Warren shunt, which is a splenorenal shunt for portal hypertension. He was the first Abramson lecturer here in 1972, and that professorship has continued on. Some of the guys in town who I thought were influential in helping Shreveport's Department of Surgery continue where it was from the 30s and bridged it into the 50s. Dr. Charles Black Sr., as we talked earlier, from Westlake. He graduated undergrad and medical school here in World War II. Almost all of these guys were either World War I or World War II vets. And then Dr. Charles Knight. This is Dr. Black here, Dr. Charles Knight's over here. Made a huge impact on my career. He was one of the suits who every Tuesday morning you would round, Kevin remembers this well, round with Dr. McDonald, and the suits would come in, and I said, man, these guys are smart. I mean, I thought the academic surgeons were smart, but the private guys in town were really a stand-up group of guys. We learned a lot from them, and they would quiz us incessantly. Dean Griffin was also part of that group that, to me, really molded the decision on me doing academic medicine. Dr. Charles Knight at a young age, just after he left Mayo Clinic, and this is his family. John, orthopedic surgeon, trained here at LSU. Chuck Sr., who just retired from Highland, general and vascular surgery from Vanderbilt. Fred, he can be seen playing cards at Southern Trace or doing vascular surgery at Willis Knighton. And Dan, who's retired, was a plastic surgeon, all finished at Shreveport. Dr. Kurzweg, who was the first academic surgeon hired here by Dr. Ike Muslow. He's from Plaquemine, had an illustrious training at Notre Dame, Harvard, University of Minnesota, which was a powerhouse of surgery back then. Went to Charity in New Orleans, the Mayo Clinic, and finally ended up as professor at the University of Miami. He wanted to come home. It made a huge impact prior to Dr. McDonald's I should say, when he moved from Tulane to Shreveport. Dr. Kurzweg, Dr. Gladney has operated with him, said he was an excellent technical surgeon. He and the dean did not get along, and with Dr. Drapanis' death in New Orleans, led this great man to our institution. I'll go over his history in a little bit, but John McDonald had an impact on all of us in this room, whether you know it or not. When you go down to the archives of the library, half the archives are John McDonald. It's just amazing the things that he did for this institution. And every time I review the history of what he's done, it just totally amazes me. He was a mentor to me, Kevin, obviously Dr. Larimore, Dr. Gladney. He really started academic health care, academic medicine here. He was a true stand-up guy. He was born in Baldwin, Mississippi, got his BS in Mississippi College, and his MD at Tulane. He did a one-year internship, and I saw his name on the interns list here at Confederate Memorial Hospital before he went to New York at Buffalo, where he really made a huge impact on immunology, research, and also began transplantation there. He's a professor at Tulane from 1968 to 1977. Everybody thought he was the next line for the chairmanship. And Dr. Drapanis, who had been chair there, a rising star, who was the editor of surgery magazines, took off from New Orleans to go to New York to do the oral exams for the American College and died in that plane accident, killed, I think, 200 people. Dr. McDonald thought for sure he was next in line, but got passed over by Dr. Watts-Webb, who was hired as chair. And Dr. McDonald had been up to Shreveport to talk about transplantation for quite some time. It was a natural for him to come up here, and this is where he started, I think, the greatest 20 years, 25 years of this institution. He became chairman and professor here, and for the first time ever, we had our own chancellor and dean, and he was given that position rightfully so and made such a huge impact even after being department chair from 2000 to 2009. He brought heart, liver, kidney, pancreas transplantation here. The first liver was done at this institution, believe it or not, which was a liver in a small young lady. He made a joint venture with Willis Knighton with a handshake, with nothing more than a handshake. He and Jim Elrod really formed what was the beginnings of what I thought a great relationship with education and also the private hospital system. Level 1 Trauma Center, first one in the state. Not charity, but Shreveport. He was president of CEOP, UNOS, started the Burn Center. Kevin remembers that well. He had us an endowed chair, obviously, and he really expanded residencies, not only to E.A. Conway and the VA, but we also had a presence in Alexandria for some time. He was here all the time, even before his chairmanship here. Came, he hated this picture. He wanted to take this out, and he didn't have his glasses on, so he didn't propel well here. But this is he and Dr. Jacoby, who was a PhD, who he hired in immunology and a kidney pump. This is after the first liver transplant here. I was holding sticks as a med student. I'll never forget that. We had, I think it was 3 or 4 teams of us that had to hold a big old Diva retractor for that first liver, and he was yelling at us. You wouldn't believe. Wouldn't be tolerated now, but I knew he loved us. He was disappointed in some of the aspects of mortality, but continued to reinvent the wheel here at LSU, brought it to Willis Knighton, where he's extremely successful and continues to be. And then finally, obviously he was tapped for the chancellor and made a huge impact. Kevin took over as interim department chair after that. But I can't say enough about Dr. McDonald. He did things that nobody had done in 140 years. He was able to work with the legislator, work with the governor. He had a political savvy that brought things to Northwest Louisiana that I never thought was possible. Charity Hospital, or LSU Hospital at that time in the late 1970s, was the most successful academic hospital in the United States. Some of that was true, some of it was not true, because we got so many disproportional share funds at that time that made us look like we made almost $100 million. So there was some truth to that, but it was also because Louisiana donated a huge disproportionate share to LSU. And Donnie, you remember that article. Dr. McDonald just couldn't believe it. First heart surgery here, Dr. Stan Shelby was here, I think, a couple of years. So a lot of firsts at LSU here in Shreveport. Dr. Stan Shelby did an aortic valve replacement on an endocarditis patient that lived about, I think, 1 or 2 days. But heart surgery stayed there, and Dr. Tucker, that Dr. Gladney and I were just talking about, came and actually did congenital heart surgery here, acquired heart surgery here, and propelled Shreveport into a known commodity. We think we know trauma. Well, I don't know if I was surprised at reviewing the history of not knowing about this mass casualty that happened in New London, Texas, which is not that far from here. There was a natural gas leak in a school that caused almost 600 casualties. The first mass casualty situation that LSU ever had to use. We made 100 beds available immediately. A lot of these patients were burned. They were brought in, and this was in the 1930s. Back when the oil and gas industry was just rampant and a lot of the safety measures had not been initiated. But this was our first exposure to major trauma, and we rose to the occasion. So what about the residency? you can categorize a residency as the American College of Surgeons approved, but residency started around 1900. There were interns, not only at LSU proper, or I should say Charity proper, but Highland had a few interns. T.E. Shumpert had some interns. They weren't all certified, but they got a great surgical training, and this was one of the most sought-after areas for residents to come for their surgical training. So how many residents have we trained? This is a ballpark figure. I would say at least 500. Now, if you look at the number of trainees that went through Charity Hospital System and Confederate Memorial, it's in the sevens or eights of thousands. So, but not all of them were surgery. It was accredited in 1951 by the American College of Surgeons. 27 surgical chiefs, as we previously described. There were 6 permanent chairs from 1968 to present, 2 acting chairs, and this was in 1977 up on the 9th floor after they finally air-conditioned the rooms. Crazy. I can't even imagine being up there during that time period. So our graduate medical education started in the 1890s once again. Visiting staff were the norm until 1977. So the hierarchy then was there was a chief resident here. You had 2 or 3 residents under them. And the attending would come by once, maybe twice a week, or for the big cases that the chief couldn't handle. So the chief resident taught the underlings, the 3rd and 4th years. There was a 4-year residency back then. It was not a 5-year residency till 1960s. But the chief resident was the god. He would sleep in the command module upstairs, what they called it, and run the ED, run the trauma, run the burns, and help the junior faculty with that. 77 doctors were on visiting staff. They made no money. They came because they believed in Charity Hospital, and they believed that the indigent needed good health care. And these were some of the most successful doctors in town that would come without charge. Some of the graduates here in 1935. Yep, you had duties with the ambulance too. This was our ambulance that we ran. You had alternating every 5 nights. You had to drive the ambulance around for trauma, and the trauma was there. You'd be amazed at the amount of penetrating trauma from the 1910s to all the way to now. Some of the resident staff from 1928 to 1929. Dr. Sanderson here in the middle. House staff once again. And finally, the lone and first woman surgeon, 1938, was the first female resident, surgical resident, and it from thereafter there were had the cohesive force of keeping the Department of Surgery together with the visiting staff. See if you can figure out who this is here. Dr. Griffin. Okay, you may not know this gentleman. Looks like he's the most wanted list here, but he lives in El Dorado, Arkansas right now. Bill Norwood, thank you, Donnie. One of the most prolific robotic surgeons in the United States for quite some time. Embraced it early and did just a huge. And Bill, if you're watching the YouTube, thank you. Great guy. This is the match list, the National Rank Order list in 1967. And Dr. Lawley, I hope you're over in Monroe watching this because, you're lucky to have gotten in. There was no national ranking program. This was the chairman's list written out and typed out, and he circled who was coming to the Department of Surgery. Pete Blanchard, who ended up being an internal medicine doctor later on. Here's Dr. Lawley down here, and I guess it is in alphabetical order. So Dr. Tommy Lawley was ranked and became an intern shortly thereafter. That's the way match was run then. There was no computer at that time. In concluding, we had 148 years of surgical training. How do you want to parse this is up to you. We were affiliated with the university for 48 years, but we had 100 years where there was no university affiliation, and the visiting doctors took care of tens of thousands of patients. And if it would not have been for visiting doctors here, we would have had a place where training would not have been taken care of appropriately, patient care would not have been taken care of appropriately, and I think this place may not have ever had a medical school, I can tell you. So American College Certified, 1951 is when we started. So that gave us 75 years. We did quite well without the American College. And then due to stratification and compliance for 73 years with the American College, and they started certifying programs in the late 1930s. Not sure why the delay was. We were so progressive in Shreveport with surgical care, why between 12-year hiatus that we really didn't seek certification by the American College. Hospital affiliation, we were Shreveport Charity, called Shreveport Charity for 77 years, Confederate Memorial for 23, and a sundry of names thereafter, and I'm sure it'll continue to change. So how did I kind of categorize the eras? Well, there was no doubt. From 1872 to 19, it was the Wild Wild West. You know, you had surgeons who were not trained, still delivered good health care. You were a combined OB, GYN, family practitioner, and surgeon, had privileges. You had no problem getting those privileges. And then in 1910, the Flexner Report came out where the federal government hired Dr. Flexner to go around to all the medical schools in the United States in the training programs to see where do we stand in the state of medicine. And he brought back a horrible slashing report that the state of health care was nowhere where it should have been. Doctors were basically indentured servants that had trained and never had any didactics, didn't know antibiotics at that time, and made a huge push for the U.S. government to entail a regimented program for certification. The American College was in on this in 1917. They started with a very aggressive program to try to get things certified, and there you have it thereafter. World War II made huge advances in surgical technique. Chest tubes were unheard of prior to World War II. Improved technique, American College oversight. And in 1950 to 1976, there was a ton of money from the U.S. government, and the technological era kind of took over. Things started happening there, chemotherapy, radiation therapy, neoadjuvant therapy, things that you would not have predicted was available because of the monies in the United States. And you just can't say anything else but John C. McDonald's era between 77 and 2010. He made things happen magically that couldn't be matched by governors, by senators. He made this place just what it is today, and did it in a Southern gentlemanly fashion. Very rare in Louisiana politics. I don't know how he did it. And then lastly, and I think probably one of the most controversial times, is our privatization era, that we're now in the midst of Bobby Jindal changed this all up in 2013 by privatizing 9 of the 10 charity hospital systems. And whether you love it or hate it, I think it was the right thing to do, because the charity hospital system, number one, needs to treat private and charity cases, but it just was a huge burden, and there's no way they could finance that. And we were one of the last states to be able to do that. So where do we stand with the future for our surgical program? The financial stress has made us undergo some adaptive economics. We have to converge to protect ourselves from liability. Now, I don't mean legal liability, but financial liability. So you see University of Arizona and Banner, LSU Ochsner, Duke, Wake Forest, University of Miami have all got corporate structure and corporate partners now. And you can't go anywhere where the corporate medicine structure and hierarchy is felt in academic medicine. So we're going to get through this. It's been a change and challenge for me to come back with Ochsner's presence. A lot of changes, a lot of challenges, having to look at, allocation of resources like I've never had to do before. You guys have felt it, especially with the pandemic. So with changes in Medicaid reimbursement, Alex and I wrote this paper about how it could change 2 or 3 years ago, how Medicaid reimbursement could actually change the referral base. It could hurt some of our surgical education. We're seeing it now. Our department is down 10% because of changes in not basically referral bases, but the patients have access to places that they've never had access before. So I still think we're going to have to rise to the occasion. We're going to have to expand our footprint in our training centers. We're going to have to move our residents to places where we send them to get trained, and we don't just stay here in the mothership. And this has come from the residents. When I asked them how can we expand to more general surgery cases, they came to me and said, we want to move out in the community, see some more. I think this is exactly right. And our continued liaison with Donnie and Dr. Zabari and Willis Knighton, we can't let the powers to be prevent us from graduate medical education being shared in a city of this size. And I think we'll continue to do that. And we'll integrate our hospitals, our specialists, and we've got a great future here. I'm honored to be chair here. Don't know what I would have done without this portion of my career with my residents and with their input. You know, I think the State of the Union is very healthy for this program, and it will continue. Patients that need therapy, need treatment, need surgery are out there, and they'll continue to come to us because I think we have some of the best physicians in the southeastern United States. Thank you very much. I'll be happy to entertain any questions if I know the answer. Thank you. Dr. Altman. Okay.
Do what he did in a southern way. Dr. McDonald gained the respect of everybody he worked with by his actions. Back in the early 90s when he was setting up the level 1 trauma center, I remember this well. I had just come on faculty. He was sitting at the head of the table. We had one trauma surgeon. Coming in. He said, boys, I've got a sign-up sheet here for everybody to sign up for trauma call. And he said, I'm going to put my name in several times, and I'm going to pass it on around and let you boys fill in the rest of it. So that's why he participated. He was 65 years old at the time. Same thing with transplants. 70 years old, he's over there in the middle of the night at 2 o'clock in the morning doing a liver transplant at 70 years old, putting his name on that call schedule every night with people that were 35, 40, 45 years old. That's how he did it. But he gained the respect by showing that he didn't ask anybody to do anything he wouldn't do.
Couldn't agree more. When I sat with him, as I was with him for 8 years, I came back to do heart transplants. I was with him for 8 years, and I told him I was moving on. And he says, Keith, I understand why. You understand the decisions I've had to make. And never one time did he have to raise his voice. He spoke as a Southern gentleman. I told him what I gained from him was not in the operating room, but it was the mechanism that he got things done in a very gentlemanly fashion. Really great man. Dr. Gladney, was most of that true? Dr. Gladney and I are kind of historians along with Dr. Grimes.
Yes, sir. Well stated.
Thank you. Dr. Grimes, anything to add about the history?
No, talk about Dr. McDonald. I came here from Medical College of Georgia in 1979 based on Arlie Mansberg, who was the chairman in Augusta. He said he knew nothing about the training program in Shreveport that Dr. McDonald just got there, but he knew that Dr. McDonald would have a great system built around him.
No doubt. Well, if not, we'll transition. I'm going to have Dr. Sitt and Dr. Samra present the chairs, and congratulations, seniors.
Let there be light. Hey, all the residents, stay put. We're going to get a group photo of everybody, of all the residents that are here too.
All right, everybody, it's almost the end of the fine morning. We're going to start the usual custom we have, the tradition. We're going to start passing on the aerial picture and some signed blocks to you all. All right. It will be alphabetical order. So there you come here.
Either way, I can shoot if you want them to come up or you want them to come down. It doesn't, either way. Maybe one of them just to come down.
Yeah, come down.
Yeah, let's come down.
Oh, you sit there. Impossible. All right. So the first is Dr. Emily Adams. Congratulations. All right. Next. And next is Dr. Alex Burch. Next is Dr. Ari Gardner. All right, and then Dr. Chris Foster. Oh, thank you. So next to the chair, and this is for Dr. Emily Adams. Stay behind the chair. Yes. And next is Dr. Alex Burch. And then the next is Dr. Al. And then Dr. Chris Foster.
I'll get one with just them, and I'll read it. There you go. Big smiles, everyone. Okay. Come to the middle. Come to the middle. There you go. This is better. Very good. Anybody else we need to add to this one?
I'd like to get
Just here. Yeah. Just size, yeah, you do that. Group up. Yeah, there you go. There we go. I like that. What's the cost of a there you go. Now, you want to get everybody right?
All the residents. I don't know how you want to put them.
Yeah, some up and some
Come
down.
on, come on, guys.
You guys,
Come on.
you guys, share.
Caller, come down.